Good morning, dear friends. Hope you have enjoyed the yesterday's program. Today we are going to start with fast examination. This topic will be covered by Dr. Amol Kothekar from Tata Memorial Hospital, Mumbai. Over to Dr. Amol Kothekar. Sorry, I have just forgot.
Sir,
Sorry, I just confused. The first lecture is by Dr. Raymond Savio. He'll be talking about the fast examination. Then the Dr. Amol Kothekar will come in. So please start with Dr. Raymond Savio's lecture. Thank you.
A very good morning and welcome to your day two Criticare Ultrasound Echo workshop. Hearty congrats and thanks to the organizers for putting up this really beautiful show. We've gotten really smart with this virtual affair. So, congratulations. And well, yes, it's going to be a completely different learning experience for you people as well. Anyway, so without wasting much time, let me proceed. I'm going to give you today a fast overview of FAST, which is nothing but focus abdominal sonography in trauma, or you may want to call it focused assessment with sonography in trauma, whichever ways it's one and the same. Basically, originally it used to be called the focused abdominal sonography, but subsequently, with the addition of some of the non abdominal views, it came to be known better as a focused assessment with sonography. Now, the intention here by using fast assessment is to only answer a simple question, which is whether there is a clinical significant abdominal trauma or not by looking for the presence of intra-abdominal fluid. As simple as that. We are going to say yes or a no to the presence of intra-abdominal fluid, which may be blood, which may be urine, which may be enteral contents, whatever it is. Okay, so the intention by doing a fast is not to quantify or qualify the nature of an injury. If you want to know which segment of liver is lacerated, or if you want to know which pole of the kidney there is a hematoma, that is not fast. Okay, fast is a simple algorithmic approach to the rapid intervention of somebody presenting to the ED or the ICU, whichever the case may be, with suspected abdominal trauma. Okay, so like I told you, somebody is rushed to the ER. Traditionally, of course, in my undergraduate times, I'm not pretty sure if this is still being done, something called the diagnostic peritoneal lavage, wherein we used to instill normal saline into the abdominal cavity following sterile precautions, of course, and then get the effluent, preferably from 4 quadrants, and assess that for staining with blood. Okay, now this has a very, very high sensitivity, but naturally runs the risk of being an invasive procedure. So you may be introducing infection, or maybe there could be additional organ injury, right? But yes, it had a very high sensitivity. Alternatively, another thing, which is also the gold standard, you could be rushing the patient for a CT, which is going to give a beautiful assessment. But then, especially in a setting of hemodynamic instability, this could be pretty challenging, the transfer to a CT suite. Okay, we've seen the number of crash events that have happened in such situations. So coming to the third option, which is also perhaps the best available option these days, because these kind of fast, algorithm-directed approaches have really shown to improve outcomes, reduce time to interventions. Okay, so one such thing is the fast That's the abdominal ultrasound to tell you whether there is a free fluid in the abdomen or not. And the best part, it defeats the challenges associated with the diagnostic peritoneal lavage or a CT scan, in that it is number one, non-invasive. Number two, it is portable. And in case there is somebody who is going to be moving the patient to the radiology suite for a fast assessment, then that's not the whole idea. Okay, it needs to be done in the bedside. It needs to be done wherever the patient is received, the triage or the ED, by the first responder, who can be a surgeon, who can be an intensivist, who can be an ER physician, whomsoever. But it needs to be done in the bedside. And it is, technically speaking, a rapid assessment. In the hands of experienced personnel, it might just take 2 to 5 minutes. In any case, even if you're beginning to learn, probably not more than 10 minutes. And then it can be repeated any number of times, especially in the event of an indeterminate assessment, or when you're not very clear, or when the patient is stable and you just need a couple of repeat assessments. Probably there is not enough blood yet. You can keep repeating it any number of times, and it is reasonably cost effective. It is believed that the use of ultrasound for trauma started way back in 1970s in the European countries, but it wasn't until the 1990s, when the North American countries really started using them, that it became all that popular. And like I have shown over here, the curvilinear probe, which has a frequency of 3 to 5 megahertz. Basically, you want to look at internal contents. You need depth assessment, probably not the clarity of the image. So this is what we tend to use. Between curvilinear or a phased array, that is the echo probe, both of them are equally good enough. Some people prefer the use of an echo probe because it has a smaller footprint. So when it comes to the non-abdominal or the intercostal views for the extended fast, especially, it becomes easier because this one doesn't fit inside, right? And you can see the figures I have shown you for fast. It has a fairly high sensitivity, somewhere between 60 to 100%, in the sense that, if there's a small volume of blood, or if it is still building up, it has a low sensitivity. However, when you do pick it up, it has a very high specificity, and it has a low sensitivity for specific organ lesions, but then that's not the intention at all. We're not going to be assessing that anyways, right? So when there is clinically significant trauma, when there is organ injury, there is going to be intra-abdominal fluid, maybe blood, maybe urine, maybe enteral contents. It does not matter what. Okay, and there is a tendency for this fluid to collect in one of these areas when the person is especially in the supine. Okay, so the most important location where it also tends to collect first happens to be the right supramesocolic. So it's divided as supramesocolic and inframesocolic. Okay, and you have two supramesocolic, one is the right and the left. So the right is where you have the hepatorenal recess, okay, which is called the Morrison's pouch. I will show you more images, don't worry. Okay, that's over here. If I can use the cursor, are you people able to see the cursor? Yeah, I guess so. Yeah. Okay, and then we have the splenorenal recess, which is the left supramesocolic. You have the right and the left paracolic gutters, which is not part of fast assessment. This is just a little bit of theoretical. In terms of fast, the next view that you would be going into will be the pelvic view. Basically, we look into the pelvis behind the bladder to see for collection of fluid. So the main abdominal views that we are going to be seeing in fast is the right upper quadrant, which is the Morrison pouch, the left upper quadrant, which is the splenorenal, and then the pelvic, which is behind the bladder. Look behind the bladder. You need not technically be worried about the paracolic or the pericolic gutters or the left and right inframesocolic areas for now. That's not part of the fast algorithm. And this is all that you need to remember. Okay, nothing, there's no rocket science here. When somebody presents with abdominal trauma, the patient may or may not be unstable. If it is an unstable, when I say unstable, it's hemodynamic stability that we're talking about. In a hemodynamic unstable patient, if fast is positive, you rush him directly to the OR. There is no wasting time with observation or with resuscitation or with trying to move him for a CT. There is no point. Okay, abdominal trauma, hemodynamically unstable, fast positive, goes to the operating room. If the person is hemodynamically unstable and the fast is negative or indeterminate, then that may warrant a CT assessment. In stable patients, It's a different algorithm altogether. But then remember, FAST is especially for the hemodynamically unstable patient, where you can cut down significantly on the time between presentation to a definitive or a damage control intervention. And you can see these are mainly the views that you are going to acquire. One is the subxiphoid, mainly to look at the heart, whether there is a pericardial effusion, a hemo effusion out there because of blunt trauma, the right upper quadrant and the left upper quadrant views, and then the pelvic view. I'll just show you how you are going to be acquiring the windows. Okay, so we start the examination with a subxiphoid view. You might have seen this in hemodynamic assessment, the Rush protocols, and the cardiac windows. So immediately below the costal margin, you point up, right? You hold the probe this way with the dot orientation pointing to the left shoulder, okay? That's for the subxiphoid window for pericardial view. You might have to be doing a little bit of angulations depending upon the position of the patient. And this is the image that you are supposed to acquire. You see a 4-chamber view of the heart, the right atrium, right ventricle, left atrium, left ventricle. And of course, you are looking at the heart through the liver, okay? You can compare it with the image, the line diagram I have placed on the right side. And the point of interest over here, well, yes, you may be tempted to look at the chambers and all that, but the point of interest within the perspective of FAST is whether or not there is a pericardial effusion. Okay, that's all you're going to be looking at in the subcostal view. Next, we move on to the right upper quadrant view. So the patient in supine, right? You hold the probe vertically, the dot facing up. In fact, it doesn't quite matter, the dot up or down, as long as you are oriented to which is top, which is bottom, it's fine. So beginners preferably start with the dot on top, somewhere in the mid-axillary line, okay, at the junction with the costal margin. So this is where you get to see the liver, the hepato-renal recess, okay? So that's where you take a window. And remember, this is going to be a cross-sectional view. Your beam is just going to pass through one zone. So if you need to get a proper view, a 3-dimensional view of the area, you need to span the probe up and down. This is the kind of image you are going to be getting. That's where your probe is, the liver. You see the diaphragm, that's the bright line over here. You can see how the liver and the kidney are juxtaposed. Your window should have both the upper and the lower poles of the kidney visible. And in a normal picture, this is how you see there is no gap, or I would say the liver and the kidney are juxtaposed, okay? It would be ideal to move the probe a little up and down so that you also visualize the subphrenic area, okay? So you can compare with the image over here, the liver, the kidney, maybe a little bit of bowel or maybe a little bit of the lung could be coming in and going out during your image acquisition. That's okay. I mean, you just need to position it and wait for your views to settle down. Moving on to the left upper quadrant view, just look at the way the probe is being placed, somewhat similar to the right upper quadrant, but then you go a little posteriorly, again, dot facing up at the costophrenic area, at the costal margin. You have to go a little posterior, right? And this is the kind of image that you see, very similar to the hepatorenal recess. So this is the splenorenal recess over here. That's the spleen, that's the kidney. You need to try and get both the upper and the lower poles of the kidney into the picture. That's what you see. These two need to be juxtaposed. There is no fluid in between. Okay, fluid is typically seen as an anechoic area, a black area. Okay, sometimes when blood coagulates, it might start looking a little hyperechoic, but again, let's not confuse over there. And something which is more important when you're looking at the left upper quadrant is, more than just looking at the splenorenal recess, it is very, very imperative to go a little up and look at the the subphrenic area, because unlike the hepatorenal recess, the splenorenal recess preferentially collects fluid in the subphrenic area, even before it tends to collect in the splenorenal recess. Moving on to the last abdominal view, which is the pelvic or the suprapubic view. To improve sensitivity, we do this in both the transverse and the longitudinal axis. So here you see the transverse probe orientation with the dot could be placed right or left, depends. You just need to get oriented and you look into the pelvis through the bladder. So this is the cross-sectional view that you see, the bladder filled with urine. There is nothing behind the bladder. Typically, when there is fluid, you tend to see fluid or an anechoic area posterior to the bladder. That's the longitudinal view. I'll show you the line imaging. So this is basically showing the rectovesical pouch. Okay, this is somewhere the prostate. Again, you're not going to be assessing all that. The longitudinal view of the bladder. This is a nicely filled bladder. There is no fluid collecting anywhere behind the bladder. That is in a female. So you see the bladder over here, well distended with urine. And then there is the uterus. Okay, just compare it with the image I've given on the right side. There is the uterus. So maybe there is fluid collection in the recto-uterine pouch, the pouch of Douglas, or it could be in the vesico-uterine pouch. Okay, typically in the supine position, you expect fluid to be collected in this area, that is the recto-uterine pouch, right? So these are the views that you will be seeing in the pelvic. Now, if you would like to slightly extend the application of FAST, like I told you, with the inclusion of non-abdominal views, we call it as the eFAST or the extended FAST. So these are the 4 windows that you're going to be additionally looking into, nothing but the right and the left parasternal views. Maybe see somewhere in the second, third, fourth intercostal spaces, somewhere near the mid-clavicular line, left and right. And then we also look into the flaps points. You must have learned in your lung ultrasound, the posterolateral alveolo-pleural syndrome points, which is somewhere in the mid-axillary, which is almost similar. It's just a little higher up compared to the left upper quadrant and the right upper quadrant views, which we just described. Okay, let's see what you see over there. So that is a right flaps point view where you see the lung, you see the liver, the diaphragm, and you can appreciate this anechoic area, which is fluid in the pleural space. Again, it can be blood, it can be just a straightforward pleural effusion. Okay, it may be a simple fluid, it may be a complex fluid, but then all that is again not within the perspective of FAST. You will be taught these things in lung ultrasound. So FAST is positive, or eFAST is positive when you find something like this, right? So the next view, that is the left flaps point. So that's the spleen, diaphragm, the lung up above there. And there's a lot of anechoic space over there. So there is fluid in the left flaps point, right? So this is positive, eFAST positive for fluid in the left pleural space. What we are seeing here is probably one of the parasternal views, maybe the right, maybe the left. You get the two, I'm sorry, I lost my cursor. Yeah. These are the 2 rib shadows, and in between you see the pleural line over there. I'm sorry, this is just an image. I do not have a video over here. So you are supposed to basically look for the presence or absence of pneumothorax by observing for the sliding sign. Okay, I'm sure you people are familiar. The presence of a sliding sign over here, the pleural slide, virtually 100% rules out the possibility of a pneumothorax. Okay, the absence of a sliding sign, however, could be pneumothorax, could be any other condition as well. That will be dealt with in your other sessions. On your M mode, this is a characteristic seashore sign which you see, which again means to say that this is a normal lung. So there is no pneumothorax here, part of the extended FAST. In the same window or in the flaps view, you get to see the A profiling or the B profiling. Well, this doesn't answer, this is not necessarily part of the eFAST question about abdominal injury or presence of fluid inside. It may be an additional finding that you would just want to interpret with caution. Now, another view here, what you're seeing is the absence, is probably the absence of sliding sign. That's the barcode, so meaning to say there is a pneumothorax. Okay, that's one of the parasternal views. And This is going to be a hallmark sign or a pathognomonic sign for the presence of pneumothorax. What is this called? Yes, the lung point. Okay. So you basically have this barcoding and then you have the lung moving in and moving out. Okay. So when you are able to see this view between the ribs, you get to see the lung point, you get to see a small part of the pleural line sliding, and then there is one segment of it which is not going to be moving. So this is hallmark of pneumothorax. These are basically the additional views that you will be seeing in an extended FAST, nothing but the right and left flaps, and then the right and left parasternal views. Now, if I have time, I can just quickly run you through some of the pathological images that you may witness, you may encounter while handling these patients. What do you think that is? Well, yes, yeah. So that's a subcostal view. You're looking at the heart, right? It's not the best window, probably. Don't talk about LVH and all that. That's not my point of interest here. What we see is a nice black anechoic area all around the heart. So there is pericardial effusion, okay? That could be blood, that could be fluid, whatever it is. But then in the context of blunt trauma, most likely that's a hemopericardium, okay? So in case there is some technical challenge in acquiring this view, maybe because of the habitus of the patient, or maybe because of presence of surgical emphysema or some dressing or pain that the patient is not allowing you to poke in there, you may want to resort to any of the other echo windows. The point is, look for hemopericardium. What you are seeing over here is the right upper quadrant view. We see a very nice looking liver. Of course, there is this kidney, both the upper and the lower poles are visualized, and you see this anechoic area. There is fluid in the right upper quadrant, okay? So there is blood, or it can be fluid. Again, I just keep repeating, it doesn't matter what it is, but it looks to be a simple fluid. I don't see any floaters over here. The diaphragm, maybe if I move a little up there, I can see the flaps point. I can also see whether there is fluid in the pleural space or not. Okay, so I would like to mention something, that is this Morrison pouch also happens to be the first place which gets to collect fluid in a supine position. So if you're beginning your fast and you already see this, you can almost conclude the fast saying fast is positive. And if this person is hemodynamically unstable, you just move him to the OR. Okay, as simple as that. You don't have to be struggling with any of the other views, I would say. What we see over here is the pelvic view, a cross-sectional view of the bladder. Well, obviously, I'm not moving in one particular pattern. It's not the same patient. I just wanted to show you a few pathological images. And you see this anechoic area behind the bladder. So there is fluid in the pelvis. Okay, the rectovesical pouch has fluid out there. What do we see over here? Yeah. So that is the uterus. This is also the pelvic view. Okay, so that is the bladder. There is urine within. This is the uterus. And there is fluid collection in the rectouterine pouch. Okay, the pouch of Douglas. What we see over here is the spleen. So that's a splenorenal recess. We are looking at the left upper quadrant view. There seems to be a lot of fluid anyways. But then if you can focus over here, there is a thin rim of anechoic fluid. Like I told you, if you see this, maybe you may just want to move a little higher up to look at the subphrenic area. It is possible that there is a greater amount of fluid accumulating above the spleen and below the diaphragm. This is what it might look like if you move the probe a little up. Okay, you can see the subphrenic fluid collection in this region. Okay, that's a spleen. Of course, this is not the same patient. Okay, this is a different image. So you are already seeing a whole lot of fluid in the splenorenal recess as well. What we see here is the paracolic gutter. I'm not able to tell you if it is the right or the left, doesn't matter. Like I told you, it is not part of the FAST algorithm. I just wanted to show you how it might look like. So that's a cross section of the bowel, and you see fluid out there. Okay, so that's in a nutshell about FAST. You just have the traditional 4 views plus additional 4 views of the extension of FAST. So you start examining a patient presenting to you with suspected blunt abdominal trauma. Look at the subxiphoid view for the pericardial view. look at the right upper quadrant, left upper quadrant, and then we focus into the pelvis. And then the extended views, namely the right and the left flaps points, the right and the left parasternal points. You conclude saying the test is positive, negative, or indeterminate. That's all. You're not going to be classifying the lesion or anything. Positive if you identify an anechoic collection in any of these areas analyzed. Negative if you do not see anywhere. So if the patient is unstable and if the test is negative, you may want to repeat it again, or you may want to resuscitate, stabilize the patient, and then move him for a CT. In the process, in this time duration, repeated investigation really pays off. Now, if for some reason you are not able to analyze, if you're not able to complete the fast, probably for any of the limitations that I told you, pain or dressing or surgical emphysema or whatever it is, if you're not able to complete, it is called indeterminate. Okay. So patients who are hemodynamically unstable and indeterminate, again, that warrants further evaluation. So the test result can only be positive, negative, or indeterminate, nothing in between all of these. Different institutions may devise some, like this is borrowed from one of the institutions where they have this as a printed card. You just need to pick it. There is a little bit of quantification over there, which is really not needed. Okay, you just need to say there is fluid in this quadrant, yes, no, indeterminate. That's all. You may want to design something for your own institution. Like any other intervention, FAST also has its own limitations or pitfalls. I have already told you that it lacks sensitivity because sometimes it takes time for fluid to collect, or maybe it is a retroperitoneal fluid which is not picked up in FAST, or maybe the volume of fluid is so little. You may have to sometimes give a little bit of a Trendelenburg position to see the fluid collect in the Morrison's pouch. So for various reasons, or maybe the person is a little less experienced. For these kind of reasons, it lacks sensitivity. Nevertheless, the specificity, once you identify an anechoic zone, it is positive. Okay, the specificity is very, very high. And therefore, it may miss early or a slow developing intra-abdominal hemorrhage, wherein we need to consider serial images. Like we discussed already, other limitations, obesity, surgical emphysema, the presence of a lot of bowel gas, definitely air is a very, very bad conductor of ultrasound. And it turns out that only 10% or less than 10% of fast users can actually detect fluid, which is less than 400 ml within the abdomen. So you may want to use those maneuvers of Trendelenburg position if also clinically, feasible, if you are allowed to do such things. And in pediatrics, again, the technique needs a little bit of subtle modifications, in terms of window acquisition and as such clinical challenges handling a little crying baby, right? So that's in a nutshell about FAST. And, keep in mind again that the entire intention is only to reduce the time to intervention in somebody who is hemodynamically unstable because of an intra-abdominal bleed or a significant intra-abdominal injury like trauma to the intestines with, perforation and enteral collection within the abdominal cavity, something like that, and not to quantify or qualify lesions. Okay, with use, you can really reduce the time required for performance of a fast examination, and the general principles of ultrasound apply to fast as well. Thank you. A very good morning and
Good morning, everyone. I am Dr. Amol from Tata Memorial Center, Mumbai, and I am talking about abdominal and thoracic aortic aneurysm and dissection ultrasound. I declare no conflicts of interest. Now, why we should learn aortic ultrasound? Because prevalence of aortic disease increases exponentially with age. So these are more common in patients who are elderly. And talking about aneurysm, the patients with aneurysm, they are asymptomatic and unaware of their disease. Rupture of aneurysm has a catastrophic course with mortality close to 90%. However, early identification of aneurysm helps in early intervention. Talking about dissection, the dissection can mimic or coexist with acute coronary syndrome. However, thrombolysis can be disastrous in presence of aortic dissection. So that's the reason why all of us should know how to do aortic ultrasound to pick up these important pathologies. What are the indications of aortic ultrasound in emergency department or ICU? So it should be done for any patient presenting with shock, any patient presenting with chest pain, especially the tearing or ripping type of chest pain. The symptoms suggestive of dissection. If the patient presents with abdominal pain, this patient should undergo aortic ultrasound. The patient presenting with hematuria or hematochezia or palpable abdominal lump or any trauma victim, in this patient the aorta should be screened. In stable patients, aortic ultrasound is required for patients having risk factors like age, smoking, hypertension, obesity, or pre-existing disease or family history. Now let's review the anatomy of aorta and its branches. In thoracic aorta, an arch of aorta gives three branches, that is brachiocephalic on right, left common carotid, and left subclavian. These are the important branches which can be reviewed under ultrasound. In abdominal aorta, the first branch is celiac axis or celiac trunk. The second branch is superior mesenteric, followed by two renal arteries, and later the aorta bifurcates into two iliac arteries. Now, we'll talk about the classification of aortic dissection. The two classifications are available. One is D. Baker's classification of type 1, 2, and 3. And the Stanford classification, the Stanford A covers D. Baker's 1 and 2, where ascending aorta is involved, and Stanford B is where ascending aorta is not involved. So why these classifications are important? Because the Stanford A or D. Baker's type 1 and 2, they require urgent surgery because they involve either ascending aorta or arch of aorta, and the patients in which only descending aorta is involved, these can be generally managed with medical management unless there is some complication. Now, what are the imaging modalities for ultrasound available for visualization of aorta? For aortic root and ascending aorta, you can use parasternal long axis or short axis view. For arch of aorta, you can use suprasternal view or you can use transesophageal echo. Obviously, TE is better because it will give you better view. For descending thoracic aorta, TE is better, and most of the descending aorta is not visible in transthoracic echo. Descending abdominal aorta, you use ultrasound with a curvilinear probe. Now talking about thoracic aorta. So you can see aortic wall, aortic root, and portion of ascending aorta in parasternal long axis view. So in this view, here at the level of parasternal long axis view with the echo probe. So this is the image which is produced. You can see here aortic wall, aortic root which is slightly dilated, and you can see part of ascending aorta. In most of the patients, you can see part of descending aorta posteriorly, which is marked here with a blue arrow. You should always remember this thumb rule in parasternal long axis view. The right ventricle, the aorta, and left atrium. all these three structures should be of same size. If any one of the structure is big, there is some problem in that structure. We're going to see some patients having aortic dissections where you can see a big aorta here. So in this image, you can see a large aorta with a dissection intimal flap. The second image also you can see a dissection of aorta. Now from parasternal long axis, you can go to short axis view, scan the heart at the level of aorta. So here you can see aortic scan at the level of aortic wall. You can see a Mercedes-Benz sign here. If you tilt the probe further, you can see aortic root. You need to give a caudal tilt for that. In many patients, you can see a descending aorta posteriorly. So in this image, you can see a descending aorta posteriorly in a parasternal short axis view, and you can very well see a dissection with an intimal flap. The next view is apical 5-chamber view. Here you are looking at LV outflow tract and aortic wall. In this view, you should check for aortic regurgitation. It's very common in patients with aortic dissection because there is dilatation of aortic roots causing acute aortic regurgitation. It is present in at least 2/3 of patients of aortic dissection. Suprasternal view is very difficult to obtain in critical ill patients. So this is the view produced here. By putting the probe here in the suprasternal notch, we use the echo probe for this. You can see aorta here and the 3 branches. In the next slide, I'm going to show you a normal and abnormal view. This is a normal view here, the 3 branches. And in this view, you can see the 3 branches and plus a dissection of aorta here. Now, going down to lower thoracic and abdominal aorta. We'll first review the aorta in long axis. So I put the probe here in subcostal window, and I can move the probe down over the abdomen. I can see aorta here to the liver window. I should be sure that this is aorta and not the IVC. I can put Doppler and check that. Also simultaneously, I tilt the probe to check the IVC. I reconfirm it. So now I know that this patient has this is the IVC and this is the aorta. So now I'm sure what I'm measuring. The Doppler also gives me a better confidence to differentiate between IVC and aorta. Now, if I move the probe further down, I can see abdominal aorta and its branches. The first branch of abdominal aorta is celiac trunk. The second branch is superior mesenteric artery. So both these branches can be very well seen under ultrasound, provided the patient bowel gas allows you. That's why you need to use an abdominal probe. If you can't see anything, apply gentle pressure, which will displace the abdominal loops, bowel loops, and it will give you a better image. In this image, you can, this is a real life image of a person with in the long axis of aorta. You can see celiac trunk and superior mesenteric artery. You can also see some bowel gas here. So with the help of our ultrasound probe, with gentle pressure, the bowel gas may disappear. If I put a Doppler, I can see both celiac trunk and superior mesenteric artery with the color flow. Now, the first image is normal. The second image, I can see the dissection of aorta in the abdominal aorta. I can see a dissection with the intimal flap. I can tilt the probe, rotate the probe 90 degrees, and I can see the subcostal short axis view. I can trace the descending aorta in the thoracic to the abdomen. Now, in short axis, I will visualize both IVC and aorta together. I should be able to differentiate it. The IVC is lying inside the liver window. The IVC is collapsing with respiration in spontaneously breathing patients. The aorta is pulsating here. If I put color Doppler, I can see the definitive difference in color pattern and the flow pattern between IVC and aorta. As I move the probe down, I can see the celiac trunk in cross section. This is the origin of celiac trunk. The 2 branches, that is left, that is the common hepatic and splenic artery. And This particular image is known as Siegel sign of ultrasound. So this is one image of celiac trunk. So I can see aorta and celiac trunk. Only part of celiac trunk is visible because of bowel gas. Now, if I move the probe down further, I can see the aorta with superior mesenteric artery and superior mesenteric vein, and this is the IVC with the renal vein here. Now, never get confused between aorta and spine. So this is aorta, which is a complete circle. This is the spine, which is only half circle and a shadow below. So this is again a real life image of aorta and superior mesenteric artery. Now here there are two images. The second image, I can see there is a dilated aorta with a dissection flap. In this image, there is no dilatation of aorta. This is not aorta. This is a shadow of spine. I can see aorta here. This is a complete circle. I can see a small SMA here. So never get confused between spine and aorta. Now here, I'm showing you aorta, which is bifurcating into two iliac arteries. And you should always try to trace the aorta till the bifurcation, because this is very common site of aortic dissection. So as I previously emphasized, we should be able to differentiate between normal aorta. So this is normal aorta, this is abnormal aorta, and this is the spine. Now, when you identify a normal aorta, you can also put a Doppler and check how is the flow. So in these images, so this patient has a huge abdominal aneurysm. I'd put Doppler to confirm the flow here. Again, there are few images of abdominal aortic aneurysm. So these are the aneurysm at the level of bifurcation. Once you identify aneurysm, you should be able to measure the diameter of aorta. It's very important how you are going to measure diameter. The six different techniques have been described. So if you measure, start your measurement from the outer layer of anterior part of aorta to the posterior layer of the posterior layer of the aorta. So since the aorta is a thick structure, you can, and when the aneurysm is has a very thick structure, so it should be very clear how you are going to measure. So if you start measuring from the anterior outer layer to posterior outer layer, it is known as OTO or outer to outer method. If you measure from the inner anterior layer to the inner posterior layer, it is known as inner to inner method. If you start measuring from the leading edge to the leading edge, it is known as leading edge method. So out of all these three methods, the leading edge method is highly reproducible, and you should never use this inner to inner method, because this kind of measurement may miss aneurysm. There can be other errors while measuring the size of aorta. You should always use both longitudinal and transverse view, so that you know where is the IVC and where is the aorta. You reconfirm it. So here I am confirming this is the aorta, this is IVC. Second thing, if you are measuring only longitudinal axis, the diameter will depend on how you are cutting the aorta. If you cut the aorta in the center, you will get a large diameter. If you cut the aorta at the side, you will get a small diameter. This is known as cylinder tangent effect. So to avoid this, always measure diameter both in longitudinal and cross section. And again, I'm re-emphasizing, you trace for the posterior wall of the aorta. The only aorta will have complete posterior wall. The spine will never have a complete posterior wall. Sometimes, if you don't get any view because of the abdominal gas, try this transhepatic view. So here in transhepatic view, if I put the probe in cross section in the axial plane, I can see IVC and aorta. Again, IVC is inside the liver window, aorta is outside, and this is the spine here. If I turn the probe 90 degree, I get a sagittal image where I can see IVC inside the liver window and aorta outside. If there's a doubt, put a Doppler and reconfirm. Now, what are the normal cutoffs for aorta to identify aortic dilatation? So, ascending aorta is slightly larger in structure, especially the aortic root, which is known as sinus of Valsalva. By and large, the ascending aorta should not be more than 2.1 centimeter per meter square. At the level of sinus of Valsalva or aortic root, the diameter should be less than 4.5 centimeter. And in any ascending aorta till the arch, the diameter should be less than 3.6 centimeter. The descending aorta, the diameter should be less than 1.6 centimeter per meter square or up to 3 centimeter. In abdominal aorta, the diameter should be less than 3. The clinically relevant aneurysms in abdomen have a diameter of more than 4. Now, just to re-emphasize the views, as I told you, for aortic root and ascending aorta using plaques or PSACs, if you find any dissection at this level, this patient needs urgent surgical intervention. About aneurysm, this is not very common site of aneurysm. You will get aneurysm at this site only in patients having congenital anomalies or connective tissue disorders. Arch of aorta, suprasternal view can be used. However, TE is better. If you find dissection here, this patient needs surgical intervention. For aortic aneurysm, it is not a very common site. Same for descending aorta. TE is better. The only difference here is if you find dissection only in descending aorta, it can be managed generally with medical management. For aneurysm, it is not a common site. The descending abdominal aorta, use ultrasound with curvilinear probe. This is not a very common site for dissection. It's a very common site for aneurysm. So these 3 points you should remember. Now, to summarize the talk, the aortic ultrasound screening is required for patients who are presenting with shock or patients presenting with clinical features like pain, like the typical chest pain with a tearing or ripping pain, abdominal distension or lump in abdomen, patient with trauma, hematuria or hematochezia. Always you remember the blind spots during aortic scanning. Most of the thoracic descending aorta is not visible in transthoracic echo. Intestinal gas prohibits visualization of abdominal aorta. For arch and descending aorta, TE is better. When you are measuring, avoid inner to inner method because it will be false negative for aneurysm. Avoid measuring IVC rather than aorta. Avoid cylinder tangent effect. So use both longitudinal and transverse section. Now, the views which are described till now, most of the views of aorta are already known to us as a POCUS provider. However, you need to look specifically for aortic pathology to identify it. And if you find aortic pathology somewhere, or if you have a doubt, screen the whole aorta. So, unless you have the aortic pathology in mind, you will not be able to see it. The eyes sees only what the mind is prepared to comprehend. Thank you. Good morning, everyone. I am Dr. Amol.
Everybody, and this is Dr. Pradeep DeCosta. Welcome to this session on critical care ultrasound and the applications. I am supposed to speak on use of ultrasound in DVT, deep vein thrombosis, and pulmonary embolism. But I'm going to talk on thromboembolic disease because that also would include some of the points which are required for the purpose of this course. I would start by the probes. Now, whenever we use probes for this particular application, we would use the high frequency transducer. And remember, these are the transducers, high frequency, meaning you'll get better resolution. So these are the transducers which have a frequency of 7.5 or higher. It may be linear or microconvex, and the procedures could be done either static or dynamic. This is the commonly used probe which we have in our ICU settings. This is the high frequency linear probe. Now coming to the veins which we can see on the ultrasound, and remember the commonest misnomer is that deep vein thrombosis happens in the lower extremities. Remember, there is a small percent of people who develop deep vein thrombosis or thrombosis in the upper extremities as well. And hence it is important that we also are familiar with the anatomy of the upper limb veins. Now, the veins are easily approached by the ultrasound, and the veins commonly approached by the ultrasound would involve the subclavian vein, the internal jugular vein, the cephalic vein, and of course, as you go distally, you would get the radial veins and other veins which could also be approached or seen very well by the bedside ultrasound. The full body, you can visualize a lot of veins by ultrasound. You can look at the internal jugular vein, subclavian vein. The abdominal part becomes a bit difficult to visualize because of the bowel sometimes and the gases in the stomach sometimes. Then you come down to the lower extremities and you can see the external iliac, common femoral veins, popliteal veins very, very well by the use of the bedside ultrasound. Now, before we come to the question of deep vein thrombosis, an important distinguishing feature, or one of the most important bedside distinguishing features you must make, is you must be able to identify or differentiate an artery from a vein. Hence, one of my first slides is going to be how to differentiate an artery from a vein. An artery is circular, it is thick walled, it is non-compressible, but remember, non-compressible by a adequate amount of pressure. If you apply too much pressure, you may end up even compressing an artery. The artery is pulsatile, and sometimes you can use the color flow to demonstrate the flow direction and pulsation for the artery. The vein, on the other hand, is oval. It is very, very thin walled. It is compressible. And again, the trick is compressible with gentle pressure. It is non-pulsatile, and sometimes the Valsalva maneuver may increase the caliber of the vein. Now, there are compressive techniques which have to be utilized or used by you while doing this application. If you compress the vein, please look at this particular image. This is the vein and this is the artery. I'm applying the compression in this direction with appropriate amount of pressure, not too much pressure. And if I have a total collapse, as you can see in this particular slide, a total collapse means that that particular vein is clear. And if you have no collapse or partial collapse, as you see on this image, it means that probably there is some pathology within that particular vein and you require to evaluate further, or based on the clinical condition, make your decisions as per that particular clinical condition. Now, you must apply firm and direct pressure in the transverse scan. Remember, the important practical point is your probe must be perpendicular to the vein. If your probe is not perpendicular to the vein, you could end up getting false interpretations of your findings, and you can end up not compressing the vein appropriately and even properly. Okay, so the important point is to apply a firm pressure. Remember, the probe must be perpendicular, not at an angle to the vein. A complete collapse of the vein means it is normally compressible, and an incomplete collapse means that it could be positive for some pathology within the lumen of that particular vein. Now, if you go to this particular clip, you would find out that this particular structure is thick, circular, pulsatile, and this is thin and non-pulsatile. This particular structure can be easily compressed. This is the vein, and the other one is the artery. Now, if despite this you have a confusion about a vein and an artery, you could apply a PW or a pulse wave Doppler, and on a pulse wave Doppler, the artery shows a phasic flow or a triphasic flow. It is pulsatile, and a vein is continuously monophasic. It can show respiratory variation, and augmentation is possible within the venous structures. If you see this particular clip, you can see that there are pulses. So pulse, 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 and pulse. These particular pulses are very, very typical of arterial pulsations. And if in doubt, you have placed your pulse wave Doppler within that particular vascular structure, you get these readings. It means that this structure is an artery, it is not a vein, and you require to take the appropriate precautions. Similarly, if you place your pulse wave Doppler within a vein, you would get phasic movement. Can you see this? A phasic movement of the blood in the vein. And if you apply a Valsalva or you give pressure to the vein distal to the point of compression, you can see a sudden augmentation. Can you see that? That's a sudden augmentation in the venous flow that happens, and that usually indicates that that vein is patent. Okay, so remember, an artery is pulsatile. If you get these sort of pulsations, it means that structure is an artery. And if you get phasic movements and you are able to augment the blood flow in that particular structure, it means that that particular structure under your probe is a vein. However, remember, this particular Doppler assessment is not, and again I repeat, it is not an essential examination for identifying DVT, but it can provide you more information of the blood within the vessels. This Doppler assessment could be utilized in anatomically difficult areas to assess, like the abdomen or the iliac veins, where these veins are difficult to assess in a normal condition. Now, let us go on to the anatomy of the lower limb venous system. And remember, many people, or the misnomer is that many people believe that only proximal DVT requires treatment. But remember, around 20% of the calf DVTs also may propagate more proximally and lead to some sort of complication. Hence, it is important that we also know and identify and understand the anatomy of the veins of the lower leg as well. Coming to the ultrasound protocols, and after the ultrasound protocols, I would cover the anatomy of the limbs. There are three types of commonly used ultrasound protocols for analyzing the veins of the lower limb. One is the 2-point compression ultrasound. The second is a complete compression ultrasound. And the third is an extended compression ultrasound. A 2-point compression ultrasound means you would only evaluate 2 points. Okay, so you scan only the groin and you scan only the popliteal fossa. A complete compression ultrasound means you go centimeter by centimeter from up to down. This is probably the most accurate, but also probably the most time consuming. And if you ask me as a critical care specialist, which one I would utilize, maybe we would probably utilize the 2-point in an emergency to make a diagnosis of DVT as the cause or the etiology of the pulmonary embolism. But if you require more information and there is some doubt in your mind, don't forget that probably you require to do the complete compression ultrasound of that particular limb to take your doubts or put your doubts to rest. The extended compression ultrasound is from the groin to the thigh and then to the popliteal fossa. So these are the three commonly used ultrasound protocols. Remember, 2-point ultrasound protocol, up groin, popliteal vein, complete compression up to down, and extended compression is groin to thigh and then to popliteal fossa. So the patient requires to be lying down in the supine position and slight external rotation and flexion at the hip. You require to start just below the inguinal ligament for your scan. And as you start your scan, the structures which you would visualize are the common femoral vein and the common femoral artery. Once you visualize these particular structures, can you see this thick circular structure, muscular structure? That's the common femoral artery. That's the common femoral vein. And as you move the probe distally, you would get the saphenous vein entering. Then you go even distally, you would see the femoral veins. I will show you a diagram of this in a minute. So remember, identify first the common femoral vein in the cross section. Remember, it comes very, very close to the common femoral artery. Once you're here, probe perpendicular, direct pressure, vein gets compressed completely, means there is no DVT there. If the vein does not get completely compressed, then make your clinical decision based on what you feel is the cause of that person's breathlessness. Now, after you have applied pressure at the femoral area, you go distally centimeter by centimeter and assess the saphenofemoral junction. Further distal movement of the probe, and you would notice the splitting of the common femoral vein into the superficial femoral and the deep femoral vein. Okay, now I will not go into much detail further than that, because the superficial femoral vein then goes medial and deep into the muscle layers. And when you approach these areas, deep areas, by the ultrasound, you sometimes have to put your hand behind the thigh to make the vein prominent. This is called a bimanual technique to compress or to look for the femoral vein or the superficial femoral vein whenever the vein goes deep. Okay, so remember, for this purpose of this lecture, remember to get the femoral artery, femoral vein in your view, then move the probe distally, try to find the saphenous vein opening into the femoral vein, and then as you go further down, you get a sign called a Mickey Mouse sign and a reverse Mickey Mouse sign. Now, can you see this? This is at the inguinal ligament area, femoral vein and femoral artery. As I keep sliding the probe down, I would find the femoral artery and the tributaries of the femoral vein. Then I move the probe further down, I would get the reverse Mickey Mouse sign. Can you see the two femoral superficial and deep femoral arteries and the venous system? As I keep on moving the probe down, I would get the popliteal vein and the popliteal artery, which is there in the popliteal fossa, and then the veins of the lower limb. So can you see this? What you require to remember is, first you see a Mickey Mouse sign. Can you identify the Mickey Mouse here? And then you see a reverse Mickey Mouse here. The problem sometimes encountered by the beginner is we tend to identify one of these structures. These are the two arteries, remember. We tend to identify one of these structures as the vein during the cannulation. Of course, it is not directly related to the lecture, but we tend to identify these as a part of the cannula and try to cannulate them, which is again disastrous. Now remember, a fresh clot may not be visible. It depends on the echogenicity. Only complete compressibility can rule out a DVT. Do not compress too much. You can dislodge the clot and cause the pulmonary embolism. Now, as the clot begins to organize, which usually takes around a week or so, the thrombi tend to recanalize and the blood flow can then start from the middle of the vein. This is called the process of recanalization. During this process, the complete compression usually is still not completely possible, and sometimes the wall appears as thickened. Longitudinal scan may help in this particular section at this particular time. An important part of your examination, remember, is please do not forget to compare with the other side. Remember, anatomical variants can also occur. Do not forget to assess the neck of the patient while assessing your veins or assessing for thrombosis. You will be surprised to find so many thrombosis found in the neck area as well. So many thrombus found in the upper limb as well. Now, a time to watch out. If you can look within the lumen, you would see a grayish area here. Grayish area here. And if you look within the lumen of the vein, you would find a grayish area here. That is the beginning of a thrombotic process in the vein. Now, if you find this particular section on your ultrasound examination, then it is best that you try to evaluate further, because if you do not treat this particular phenomenon, then you can land up in a fully developed thrombus, which is shown here. Can you see this? This is the jugular vein, which is now completely thrombosed. Again, pictures of fully thrombosed jugular veins. Okay, so I'll go forward and come to the next part of my lecture, and that is on the pulmonary embolism. Now remember, once you have identified or assessed the veins of the lower limb, there, remember, we've done the 2-point or the extended compression ultrasound, whichever was possible for us. We tried to identify if there was any other possibility of thrombosis in this patient, maybe by assessing the neck veins, maybe by assessing the pelvic veins, and maybe by assessing the veins of the upper limb. And then, if we still think that the possibility of pulmonary embolism exists in this particular patient, we require to now use these following clinical pointers to assess the patient for pulmonary embolism. What I'm going to tell you now is how to use the echo or the bedside transthoracic echo, more specifically, because transesophageal we do not commonly do. So, role of transthoracic echo, I would say, in pulmonary embolism. We could utilize the transthoracic echo for direct visualization of the thrombus. You could see right ventricular dilatation and hypokinesia. There's a particular sign attached to this particular hypokinesia with sparing of the apex, which I'll come to later. You can identify abnormal interventricular septal motion. This is because of the pressure disturbances in the right ventricle. It creates abnormalities on the interventricular septum, and hence the septal motion is compromised. You can get tricuspid valve regurgitation, and of course, you do not forget to look at the inferior vena cava in a patient who is suspected to have pulmonary embolism. This is just a tabular form. I'll just brush over these tabular forms of the findings or the abnormal echocardiographic findings in a person who has a suspected pulmonary embolism. The first one is an right ventricular dilatation and hypokinesia. You could have a septal flattening, or some people say a D-shaped right ventricle because of the right ventricular dysfunction. The compression of the interventricular septum occurs, prevents the relaxation of the left ventricle, and hence creates the left ventricle which looks like a D. So some people would call this the D sign or the septal flattening sign, which is associated with persons who have right ventricular dysfunction. Then sometimes you could directly visualize the pulmonary embolism. I'll come to a few slides on that. You could detect pulmonary artery hypertension. You could look for right ventricular hypertrophy as well. An important point which many of us fail to realize probably is how do we look for a right ventricular dilatation. Now remember, this particular slide shows the left ventricle and the right ventricle, and remember, when the right ventricle diameter becomes equal to or more than that of the left ventricle, then we would say that there is a right ventricular dilatation. So if the right ventricular end diastolic area ratio to the left ventricular end diastolic area is 0.6 to 1, you have a moderate dilatation of the right ventricle. And if you have a ratio of more than 1, it means that the dilatation of the right ventricle is severe. Okay, so please, another practical point is whenever you suspect a person to have right ventricular dilatation, please try to look at least 2 or 3 views and do not make your diagnosis only on one view. There are so many times where angulation of the probe, patient positioning, many other factors are involved and could give you abnormal signs which may actually not be present. So a good practical point would be is do these examinations in at least 2 or 3 different views before confirming the presence or absence of a sign. Now, if you look at this particular clip on the left or this particular picture on the left, you would find that the diameter of the right ventricle is definitely more than that of the left ventricle. This patient has significant right ventricular dilatation. I'll try and play a clip for you in which you have the right atrium and the right ventricle. Both are dilated. This person has definitely got a right atrial and right ventricular dilatation. This particular clip shows a thrombus in the vein. This particular clip shows right atrium and right ventricular dilatation. I've put it up just to show you or eyeballing. This is the left ventricle. This is the right ventricle. The diameter of the right ventricle is equal to at least more than that of the left ventricle. Hence, this is significant right ventricular dilatation. Note also that the right atrium also is dilated and it is almost more than the size of the left atrium. This is the D sign. This is the parasternal short axis view. Look at the right ventricle. The right ventricle sits like a cap on the left ventricle. When the size of the right ventricle increases, there is an abnormal pressure which is exerted on the interventricular septum. The left ventricle looks like a D, and you would have the relaxation abnormalities of the left ventricle, which will compromise its function. This is because of the abnormalities of the right ventricle. This particular sign is called the D sign. Okay, another clip in which you can see an enlarged right ventricle. Can you see this? This is an enlarged right ventricle at the top of the screen. This is your left ventricle. This is another view also demonstrating significant right ventricular enlargement. Okay, sometimes you could see a clot. If you look closely, this is a clot in between the right atrium and right ventricle. Sometimes you could do a parasternal short axis at the level of the aortic valve, and at that particular view, remember this is the main pulmonary artery, it branches into the right and the left. If this patient has a suspected pulmonary embolism, you could get a dilatation of the main pulmonary artery, and sometimes you can even visualize a saddle thrombus which actually sits on this particular bifurcation. Okay, so this is again visualization of the thrombus directly. This is a parasternal short axis view at the level of the pulmonary arteries. Sometimes you look for tricuspid regurgitation. Can you see when you apply a color Doppler, you can see the backward flow of blood from the right ventricle into the right atrium, and this is a tricuspid regurgitation. Now, based on the velocity of this tricuspid regurgitation, you could actually estimate the pulmonary hypertension or the pulmonary artery pressures. The pulmonary artery pressure is estimated by adding the value of this particular regurgitant stream to the central venous pressure. That would give you the rough pulmonary artery pressures. Okay, this is how you would estimate the pulmonary artery or the pressure by estimating the velocities of the tricuspid regurgitation. Now, do not forget to look at the IVC. the IVC is dilated and turgid in a case of pulmonary embolism, as you can see in this particular clip. And this clip is just to show you how the IVC is dilated. Another sign, and remember, this is one sign which can be utilized. It is not a very specific and not a very sensitive sign, but if you see it, don't forget to think of pulmonary embolism. And this is called the McConnell sign. So despite moderate or severe right ventricle free wall hypokinesia, remember the apex is spared and you get a right ventricle apex which contracts. So this particular portion of the right ventricle does not contract at all, and this particular portion or the apex contracts vigorously. This is called the McConnell sign. So in this particular clip, you can see the apex contracting very, very well, and you can see this complete hypokinesia of the right ventricular free wall. If you look closely at this clip, you will appreciate that the right ventricular size is almost equal to or more than the diameter of the left ventricle. So this particular patient has a moderate amount of a right ventricular enlargement. He is demonstrating free wall hypokinesia and he is demonstrating apical sparing. This particular person has a McConnell sign. So this particular person has a sensitivity of 77% and a specificity of 94% for the possibility of pulmonary embolism. Okay, so now to conclude, remember I started first with a discussion on the veins which are approached by the ultrasound. I mentioned very clearly that not only the veins of the lower limb, but the veins of the upper limb also should be evaluated. You should evaluate the neck veins and do not forget to evaluate the pelvic or the abdominal veins if you are strongly suspecting that there is a thromboembolic phenomenon in this particular patient. The deep vein thrombosis can reasonably easily be diagnosed at the bedside. It can be reasonably easily diagnosed by the use of ultrasound at the bedside. The learning curve for this is not too difficult, and even beginners could be able to master this technique very easily. Usually, DVT and pulmonary embolism go hand in hand. In pulmonary embolism, I told you about the various signs, right from the right ventricular enlargement to the McConnell sign, to estimation of the tricuspid regurgitation, and also in the identification of the thrombus in the veins as a complete diagnostic feature of the pulmonary embolism. So remember these signs, the D sign, various signs which can give you a clue to pulmonary embolism. And I would conclude my lecture with that particular slide. Thank you once again for giving me an opportunity to present to you.
Hi everyone, I'm Dr. Kedar Turaskar. I'm a consultant intensivist from Wokhad Hospital, South Mumbai. In the next 30 minutes or so, I'm going to talk on ultrasound guided vascular access. So the fact remains that central venous cannulation is one of the most common bedside procedures done in critical care unit across the world. And it's also fraught with significant complications. So the problem is the complications, and they can be life-threatening. You have a pneumothorax, tension pneumothorax, it can be life-threatening, a hemothorax, arterial punctures leading to hematoma formation in the neck, groin, mediastinum. And of course, the bane of every intensivist, failure to obtain access, that can also be a problem. The complications are worst in cases of emergencies, patients having comorbidities like underlying bullous disease, emphysema, coagulopathy, thrombocytopenia, the contralateral pneumothorax, the hemothorax. So all these can add to the complications. Of course, inspiratory vein collapse, which is very common in hypovolemic patients, can be a big problem to get the central line in. High pressure ventilator settings, like in patients with ARDS, especially in this COVID era when you are ventilating ARDS patients with high PEEP, can be a problem. Previous attempts, more than 3 punctures can be a problem. Previous complications, arterial punctures, pneumothorax can be a problem. And of course, in inexperienced operators, less than 50 CVCs can be a problem. Anatomical constraints also is a major problem. We have a diameter less than 5, we have intraluminal thrombosis, we have anterior carotid artery in relation with the vein. So all these problems can add to the complications. So why ultrasound? Why not the routine landmark based CVC guided technique? So it allows visualization of anatomy prior to an invasive procedure and thereby detects abnormal anatomy. It identifies interposed structures. It gives you a better location of the target. And more importantly, it can prevent an invasive procedure being attempted when not indicated. Now, the standard of care is obviously ultrasound guided central venous catheterization. And 2001 Healthcare Research and Quality Evidence Report also says that it is amongst the top 11 highly proven patient safety practices. So what are the methods of central venous cannulation via ultrasound guidance? One is the landmark based central line, which is done without ultrasound guidance. And of course, you have the ultrasound assisted central line insertion, which is the static technique, or the gold standard, which is ultrasound guided central line insertion, which is a dynamic technique. So we are going to discuss about all these techniques in the next few slides. So what are the advantages of ultrasound guided venous cannulation? So it increases the success rate, the access time is less, there's a reduction in iatrogenic injuries, the number of needle punctures is reduced, and of course the infection rate is significantly reduced, thereby increasing the patient comfort and satisfaction. So what are the advantages? Central venous catheter associated bloodstream infection has been assessed and it has been found to be significantly lower than the ultrasound lower in ultrasound guided catheter insertion as compared to the landmark technique, and this has been published in Critical Care Medicine 2006. Intrajugular cannulation with ultrasound takes half as much time and half number of attempts compared to the landmark technique, and about 90% reduction in the incidence of pneumothorax, hemothorax, carotid artery cannulation, and nerve injury, which are one of the major complications associated with the procedure. Now, which probe do you use? Obviously, we prefer the linear or the high frequency probe. The logic being that higher the frequency, better are the superficial structures seen, and a neurovascular bundle in the neck is superficial structure. Okay, so you can use the convex low frequency probe with 3.5 to 5 megahertz, but that is for deeper targets. So for all practical purposes, we use the vascular or the linear probe. So what are the general principles of USG guided procedures? First and foremost, ensure patient and operator comfort. That's very important. Then line up the patient, target and transducer with the screen. Watch the screen and not your hands. That's very important. Somehow we tend to watch our hands rather than watching the screen. Use the transducer to find the needle. Make sure the local anesthetic is free of air, otherwise it will cause artifacts. Do not compromise on the aseptic precautions and probe sterility. That's very, very important. So your aseptic precaution and probe sterility should not be compromised at any time during the procedure. Do not undermine the landmarks, but respect them. So normally it's a tendency to undermine the landmarks whenever you are using the ultrasound. Don't do that. You can fall into big trouble and complications. How to differentiate between vein and artery on the scan? That's $1 million question. So artery can be perfectly rounded on the cross-sectional scan, whereas vein is ovoid, triangular, or even collapsed. The border of the artery is strictly parallel on the longitudinal scan, whereas the vein is never parallel. Artery is generally small in size. Vein is usually larger than the artery. You can see systolic pulsations in the artery, and the size of the vein varies with the respiratory cycle. You can see calcifications in the wall of the artery, not always, but yes. And you can see valvulae in the veins. Thrombosis cannot be seen, but can be seen within the vein. Okay, that's not a hard and fast rule, but you need arterial pressure to collapse the artery or avoid it. Whereas in vein, even with small mild pressure, you can collapse the vein, which is normally seen when a novice starts doing ultrasound guided cannulation. They generally put more pressure and the vein is not seen. So that is a pitfall. You have thicker walls in the artery, whereas veins have obviously thinner walls. And of course, the Doppler flow shows the arterial waveform, whereas in the vein, it shows the venous waveform. So these are a few differentiating points between the artery and the vein. So let's see a video here.
Vein is patent, but
so you can see the probe being placed on the right internal jugular artery, and carotid artery can be seen besides it. The vein is collapsible here, and you have the color flow here. Okay, that's the right internal jugular vein and the right carotid. And now you can see the Doppler flow. Okay, when you put the Doppler on the artery here. So again, going back, you can see the vein which is being collapsed nicely here. The carotid artery besides it. Okay. Then you put the color flow here. Now blue is towards and red is away. So blue and red doesn't mean that it's artery or vein. It's the direction of the flow. And this is the waveform, the arterial waveform. So this is an important slide which shows you that anatomical variations can vary on both the sides, and that's why the landmark technique is not the gold standard, but the dynamic ultrasound technique is the gold standard. You can see the right carotid artery here, the left here, okay, and Testa and his colleagues had classically published this in Academy of Emergency Medicine in 2007, and this is what it says. So you have the vein which is anterolateral in 65% of patients on the right, whereas in 69% on the left. Okay, and more importantly, you can have the vein on the artery in 32% of patients on the right side, whereas in 30% on the left side. It can be lateral, okay, bang lateral in 1% of the patients on the left, and in around 2% patients on the right. It can also be medial in a small subset of 0.3% patients. So this again justifies the need for ultrasound, without which you cannot make out the anatomical variation just based on landmark techniques. So that's very, very important. Now the site selection and preparation, you have to choose the optimal site for access with ultrasound before the site preparation. Once you choose it, you have to assess the following factors. It's the size of the vein, depth of the vein, so you know how much go in, okay, course, its patency, whether it is patent or whether it is thrombosed, the surrounding structure, and importantly the adjacent pathologies such as overlying cellulitis or vital structures which are coming in the way. So that's very, very important. The sites of central venous access are known to all: internal jugular, the subclavian, and the femoral vein. Now the most important thing is the probe sterility, and you have variety of probe covers, okay, some which are in the market, some which are indigenously made, some which are modified. So this one here is a ready-made cover which comes with the sterile jelly here, okay, and sterile rubber bands. Then you have the camera cover or the laparoscopic sleeve cover, which we generally use for ultrasound in our setup. You can have a modification of using the sterile glove, okay, and putting it on. So these are different methods. Here is one indigenous modification in which we wrap the green towel or the blue sterile towel all across the probe, and the footprint and the upper part of the probe is covered by the tegaderm. So all these can be done. This is a cover and rubber band technique which we generally use for the sleeve. And this is a small video again which will show you how the ultrasound probe can be put on. So this, you require two people for that. So this is the ready-made cover which comes with the sterile jelly. Only problem is it's a bit costly, so not all the centers use it. So cost is not a problem. This can be used. So it comes with rubber bands, it comes with sterile jelly, and it is foolproof. So You can see that there is a no touch technique which is being used. And now you can remove the air and make it airtight with the rubber bands there. And then you can apply the sterile jelly at the site and start using the probe, which is adequately sterilized. Okay. So ultrasound guided techniques are of two types, as I said, the static technique, which is also called as the ultrasound assisted technique, and the dynamic technique, which is the ultrasound guided technique. And the static technique, you have to first position the patient for the procedure, explain the patient the procedure as in any other procedure which you do in the ICU. Look at the vessels with the ultrasound and confirm the landmark predicted anatomy. So you have to mark the location at two sites, note the depth at both the sides and the angle, see the patency and the adjacent surrounding structures. Then remove the ultrasound and prepare the patient without moving. That word without moving is very important, because if the patient moves, then you won't get the cannulation right. So then cannulate the vein as usual. Now the static approach obviously has advantages over complete landmark guided procedure approach. So this is how it goes. You can mark it. So one point will be here, the other one will be here when you are cannulating the IJV. Here is the right IJV. And then you place the probe. So once you place the probe, you see the structures around it, you see the depth, you see the patency of the vein. Okay, all those things which I mentioned earlier. And then comes the dynamic technique, which is the gold standard. It is performing the procedure using ultrasound, using the needle entry and the placement. You would observe the needle entry and the placement real time. Now, dynamic technique is obviously superior to the static technique in most of the situations. Now, there are two potential approaches as per the orientation of the plane of the ultrasound image in relation with the vein, and they are the longitudinal long axis, which is also called as in-plane ultrasound image. And you have the transfer to the short axis technique, which is out of the plane ultrasound image. So there are two techniques. So this is how the longitudinal technique goes. So the needle is in the plane, okay, and this is your probe here. Whereas in transversal technique, okay, out of the plane, the needle is out of the plane, and you see only the cross-sectional area here of the vein. Okay, here you see the longitudinal area. So this is a long axis. So the vein has been cut in a long axis here. So the needle tip is observed. You can see the whole needle coming in across in the longitudinal plane, whereas in transversal plane, you can only see a tip of the needle and a reverberation artifact, of course. So this is how, again, it looks like, the image looks like in the longitudinal plane. You can see the guide wire going across here and into the lumen of the vein here. Okay, the image of the needle will be linear here. Whereas in transversal plane, the image of the vein will be circular. It is in the cross section. Okay. So the image of the needle appears like a white dot here. So this is how it looks like. Okay, on the ultrasound image, that's the internal jugular vein. This is the carotid artery, and this is where you keep the probe. This is how it looks like more closely. So you can see the transversal approach here, the probe being placed transversally. That's the pointer laterally. There is your needle. Go as close to the probe as possible in the midline here. So this is how it looks like on the ultrasound image. So this is a ring down artifact. Okay, that's the right IJV here. You have to be aware of both the images. The needle and the syringes at the same time should be there. And of course, the hand-eye coordination should be good here. This is a video of the ring down artifact. So this is how it looks like in real time. So that's the internal jugular vein. Now you can see the needle coming in. That's the tip of the needle here. And then you see the ring down artifact. So this is the schematic diagram. Again, you can see the needle coming in, and that's the reverberation artifact or the ring down artifact here. So coming to the internal jugular transverse approach, a small video again here to show you the exact technique. So you have painted, prepared, draped. The probe is in the probe is in the sterile cover, and you can see the internal jugular vein. There's soft tissue tenting here, and now you see real time here. The needle is going in the midline. You can see the artery, carotid artery here. You can see the ring down artifact. And you can move your probe in the horizontal plane so that the needle can be visible more clearly. That's the soft tissue tenting which you see. You can again see the soft tissue tenting here, and now you can see the needle will come in. So that's the needle. Go in the midline, and then you insert the needle. You can see the needle here and the ring down artifact, the soft tissue tenting, and now that you can move the probe in a horizontal plane to see the needle more clearly. So this is how it goes. So let's come to the longitudinal plane. You confirm and maintain the largest diameter image, visualize the needle course entirely and its tip and the guide wire, and this avoids inadvertent puncture of the posterior vessel wall. So you can actually see the posterior wall. So this is how it goes. So the probe is placed longitudinally. That's the pointer. Your needle will be here. Go as close to the probe as possible. That's the dictum in all ultrasound guided procedures. Now you can see here, this is the longitudinal image here. Now this is a real-time video again, which I'll run for you. So that's the longitudinal direction. Your marker is here. Your needle is in the longitudinal plane. This is soft tissue tenting. And you can see the needle going in, going in, going in. Yeah, that's the needle here. You can see the tip of the needle in the lumen of the internal jugular vein, a good backflow here. Once you get a good backflow, you have to insert the guide wire. So the guide wire entry should be smooth. Now the guide wire is being inserted here. So once the guide wire is inserted, you make sure that the guide wire is in the lumen. Now never dilate it before you confirm the guide wire being in the lumen. So that's the advantage of ultrasound here. Again, take the probe and you can see that the guide wire position has been confirmed in the lumen. So that's very important here. Okay. So that's how it goes. Now let's come to the subclavian venous cannulation. So while ultrasound guided IJV access may result in fewer complications, okay, than compared to the blind subclavian approach, the literature is less clear on the use of ultrasound in reading the subclavian access. And the problem is there is an interference from the clavicle which hinders the utility of the ultrasound in reading the subclavian venous access. But at the same time, there are studies which have shown that ultrasound guided cannulation of the subclavian vein is superior to the landmark technique and should be the method of choice in these patients also. This was published in Critical Care Medicine 2011. So there are a few anatomical considerations when you approach the subclavian vein. So right side, you have a lower pleural apex, with a higher rate of vessel trauma on the right side and higher rate of malpositioning. Whereas on the left side, it's a preferred route for immediate cardiac access, whether you want to put a pacing wire through that or you want to put a Swan-Ganz catheter. So it's a more physiological approach. And of course, thoracic duct trauma is more common because the thoracic duct drains on the left side. So you have the infraclavicular approach, which is a proximal approach. You have the axillary or the more distal infraclavicular approach, which is routinely used for ultrasound guided cannulation of the subclavian vein. And you have the supraclavicular approach. So now the supraclavicular approach, a blind approach, is rarely used because of concerns of complication when a large needle is directed towards the mediastinum, obviously because of the risk of bleed and a pneumothorax. So a good alternative to infraclavicular approach. So how do you go about doing that? So this is a video which shows that exactly where do you point your needle at. So that's the confluence of the subclavian vein, okay, to the brachiocephalic vein, and you have to go towards the opposite nipple here. So that's the needle, that's the position of the needle, and that's the direction of the needle. So that is how you have to aim the needle at. So this video shows you the subclavian vein needle tracking. Okay. So that's the subclavian vein, supraclavicular in a longitudinal manner. That's your needle. That's the soft tissue tenting which is seen. And now you can see the needle coming into the lumen right here, right here. So you can see the tenting again. Yeah. And then the needle coming here, right here. So this is another video which is showing you wire conformation.
Possibility of artery.
So this is showing you a good backflow here. You put in the wire in the subclavian vein, remove the needle, and then you conform the wire again as we did in the IJV, and you can use the fanning technique. Okay, to check for. So this is a transversal approach. You can see the guide wire. This is a longitudinal approach. So you can conform the wire in both the planes before you dilate it. So never dilate it before conforming the guide wire in the lumen. So what are the advantages of supraclavicular approach? Because the subclavian vein is closer to the lung can be visualized with the pleural surface sliding back and forth as the patient breathes. It avoids deep puncture with the needle, and it keeps the needle visualized with the ultrasound tape throughout the procedure. So that's the advantage. Now, what about the infraclavicular approach, which is more commonly used? So you identify the clavicle, the pleural line, the vein and artery before the procedure. That's very important. The pleural line also should be identified so you don't inadvertently puncture the pleura and cause a pneumothorax. And of course, the artery also should be kept away. You avoid excessive pressure. Okay. The short axis view is safer than the longitudinal view, as a differentiation between the vein and the artery will be difficult. The artery should be clearly visualized as separate structure just below the distal half of the clavicle on the short axis. And proximal to this landmark, the vein is under the clavicle and cannot be visualized directly without positioning the transducer at a different side. That's why the distal axillary vein approach is the most preferred approach with the ultrasound. So this is a video again to show you how it goes. So that's the schematic diagram and that's the ultrasound video. Now this is how you place your probe. That's the right infraclavicular approach, sorry. So that's turn the probe. Your pointer should be cephalad here. You place it at the lateral 1/3 of the clavicle. So you are approaching the axillary vein. Okay. Now that's the pleural line here. That's the artery. That's the vein. Then you go ahead and you can see this pleural line which is sliding here. That's the pleural line. So you have to avoid puncturing the pleura so that you don't cause a pneumothorax. Of course, you have to avoid the artery. That's the artery and that's the vein. So this is your needle. Okay. Your needle is directed towards the suprasternal notch here. Okay. So you can see the needle actually coming here. That's the needle track. You can visualize the needle coming through. It's showing a ring down artifact here, and that shows that you have entered the lumen. Then you can aspirate and see whether you're getting the blood. So this is how it goes. So ultrasound approach makes it really easier as compared to the blind approach here. So let's come to the femoral vein. It's a relatively constant location of the femoral vein medial to the femoral artery makes the landmark technique fairly reliable by using the arterial palpation as guide. But in particular situations such as severe hypotension or cardiac arrest or in pediatric patient, ultrasound guidance may help improve the successful femoral venous access. That's very important. Okay, so the benefit is important with novice operators in pediatric patients and in a shock state. What about HD catheters? A prospective trial of ultrasound guidance for hemodialysis access showed that the use of ultrasound improved the first pass and overall success rate, as well as lowering the rate of arterial punctures and overall procedure time. So obviously, we have enough evidence for HD catheters also. Now, ultrasound guided peripheral line, the principle of imaging remains the same. The technique is easier as compared to central lines. And of course, PICC catheters are guided by ultrasound guidance. So same principle, similar advantages. So what do the European Federation of Society for Ultrasound in Medicine and Biology guidelines say? They recommended pre-intervention ultrasound screening of the target vessels to determine the most appropriate anatomical site and patient position should be routinely used for central venous catheter placement. And to achieve the personal best skill levels for central venous placement, central venous catheter placement, it's crucial that one combines and integrates the anatomical knowledge from the landmark techniques and the knowledge gained from the ultrasound guided vascular access. So both the techniques should be combined. Now, this is a systematic stepwise approach. Identify the anatomy of the incision site and localization of the vein, confirm the patency of the vein, use real-time ultrasound guidance for the puncture of the vein, confirm the needle position in the vein, confirm the guide wire position in the vein before dilatation, very, very important in both the planes, longitudinal as well as transverse plane, confirm the catheter in position in the vein finally. So what are the take-home messages? Know the indications, contraindications, infraclavicular versus supraclavicular approach, whatever which suits you better. Technically, infraclavicular is axillary vein, long axis versus short axis in the dynamic technique. Confirm your anatomy. Wire confirmation before dilatation, very, very important. Know your probe orientation, optimize the screen position, optimize patient comfort and your comfort. Prior to getting sterile, check the vein for compressibility, very important again. Some limitations, you may be misled by the traditionally taught principles with regard to the needle direction. So that especially when the operator is inexperienced. Now, insufficient number of ultrasound machines in a certain unit can cause procedural delays. And now it's expensive to purchase and maintain ultrasound machines and to provide adequate training for all the operators involved in the CVC placement. But these limitations are not great. So that doesn't deter you from using the ultrasound machine, of course. What are the pitfalls? Incorrect use of the ultrasound machine can make it difficult to identify vascular structure. As I said, applying too much pressure with the transducer, thus collapsing the vein and rendering it invisible. That happens with novices. We have made the same mistakes when we started off. Using incorrect settings on the ultrasound machine, that again is a problem. And there are no specific complications which are related to ultrasound guided vascular access that have been reported till date. So I thank you for your kind attention, and we can take the questions.
Hi, everyone. Let's look at how to use ultrasonography by the bedside to guide neurological examination in critically ill patients. To begin with, we'll look at transcranial Doppler. Now, why do we do transcranial Doppler? There are two main reasons in the ICU as to why we may require transcranial Doppler to be done. First is in a situation wherein your patient may have subarachnoid hemorrhage. Vasospasm is a known complication of subarachnoid hemorrhage, and it usually happens later during the episode. Usually it begins around the 4th day or so and may go on till 12 days or longer. So it's very important to monitor your patient closely during this period of time when they are vulnerable to severe vasospasm. And there is no better way to look at vasospasm than by bedside transcranial Doppler. Now, how do we go about it? What is the gear that we require? The echocardiography probe with its low frequency. Remember, you need a low frequency probe to penetrate through the skull and to see the structures within the skull. So the echocardiography probe with its low frequency of 2 to 3 megahertz is ideally suited to look at the brain and the vasculature through the skull. And where do you insonate? The zygomatic arch is right there. There is a window of opportunity here just above the zygomatic process, wherein the bone is relatively thin in most individuals. And that's where it is ideal to insonate, to look at specifically the middle cerebral artery and velocity of flow through the middle cerebral artery to assess the degree of vasospasm, if any, in your patient. So you need essentially a thinned out area of the skull. There are many such areas, but one such area which is easily accessible to look at the middle cerebral artery, which is the most important artery to look at to determine vasospasm, is the transtemporal window just above the zygomatic arch. So when you insonate through the zygomatic arch, you keep your probe, the echocardiography probe, of course, just above the zygomatic arch, and the probe marker should point anteriorly. When you position your probe like that, you are looking at the cerebral vasculature in that direction. You see the circle of Willis with all the vessels that constitute the circle here. That is the middle cerebral artery, the most crucial artery that you would look for when you do a transcranial Doppler. And then you have the anterior cerebral artery. You have the posterior cerebral, which is not very easy to see most of the time, I'm afraid. And then you get the posterior communicating artery, which is relatively easy to visualize. So that's the anatomy that you look for. And in real life, when you insonate for transcranial Doppler, this is the picture that you get under ideal circumstances. That is where the probe is sitting. And at a depth of 4 to 6 centimeters, if you get a flow towards the probe, which is orange or red in color, as you see here, that will be the middle cerebral artery. In many patients, you may get the very obvious circle of Willis with the posterior cerebral artery on the same side, which again will be, the flow will be towards the probe, giving an orange streak or a red streak. And on the opposite side, if you're lucky, you may see the middle cerebral artery with its flow in the opposite direction. That's the blue color that you see here. Posterior cerebral artery on the opposite side as well, again, blue flow. So that's essentially what you would look for when you insonate through the transtemporal window just above the zygomatic arch. And that's the video clipping, one of our own patients who came to us a long time ago, a man in his 30s with severe traumatic pain injury. And when we looked at the circle of Willis through the transtemporal insonation, this is what you see. That is, as you clearly can make out, the middle cerebral artery, orange colored flow towards the probe at a depth of about 5 centimeters, which is where you would look for it. That's the posterior cerebral artery on the same side, again, flow towards the probe, so orange or red in color. And that's the middle cerebral artery on the opposite side. So this is a relatively good image that we got in the patient at that point of time. So once you get this image, the next step is to measure velocity. That is extremely crucial. To measure velocity, you place your cursor on the middle cerebral artery, and that's when you get a waveform like this. And on the side of the screen, as you can see here, the velocity appears in centimeters per second. So that is peak systole. Peak systolic velocity in this case is about 180 centimeters per second. That will be the end diastolic velocity, which in this case is about 60 centimeters per second. So you have the peak systolic and the end diastolic, but what would you actually look for? You look for the mean flow velocity, which many machines calculate for you, but even if it doesn't, it's a simple formula to calculate. The mean flow velocity is the diastolic velocity plus 1/3 of the systolic minus the diastolic velocity. So mean flow velocity is end diastolic velocity plus 1/3 of the peak systolic minus the end diastolic velocity. So this is what you would essentially look for in a patient whom you suspect to have cerebral vasospasm consequent to subarachnoid hemorrhage. So what is normal mean flow velocities? And when do you say that the mean flow velocity is high and that there is a possibility of vasospasm? Normal mean flow velocity in the middle cerebral artery is up to 100 centimeters per second. In mild vasospasm, the velocity ranges between 120 to 149 centimeters per second. In moderate vasospasm, it's 150 to 199 centimeters per second. And if the velocity is more than 200 centimeters per second, you say there is severe vasospasm. So that is the mean flow velocity. And there's another ratio that you may have to consider here called the Lindegaard ratio. Now, why do you calculate the Lindegaard ratio? It is possible that in a state of generalized high velocity flow, as in a high cardiac output state, let us say if your patient has sepsis, there will be a generally high velocity flow across the whole body, and that will affect the cerebral flow velocities as well. So to look at if it is really because of general increase in velocity or specifically because of vasospasm, you use a Lindegaard ratio, which is a ratio between the mean flow velocity in the middle cerebral artery to the mean flow velocity in the extracranial internal carotid artery. So if it is generalized increase of velocity, the ratio will not be high. But if it is localized high flow within the middle cerebral artery, obviously the Lindegaard ratio will be high. So the normal Lindegaard ratio is less than 3. In mild and moderate vasospasm, it will be between 3 and 6. And in severe vasospasm, the Lindegaard ratio will be more than 6. There is another term that you may have to consider called the pulsatility index, which is the peak systolic velocity minus the end diastolic velocity divided by the mean flow velocity. The normal value ranges from 0.5 to 1.19. And if the intracranial pressure is high, in fact, the transcranial Doppler may be useful in measuring the intracranial pressure as well, although it is not very precise from the studies that we have till so far. So if the value is more than 1.19, you might suspect a raised intracranial pressure. Now, what happens to the transcranial Doppler findings and the blood flow through the cerebral vasculature when the ICP rises? As you can imagine, when the brain becomes tighter because of higher intracranial pressure, it squashes the intracranial blood vessels. The caliber becomes very narrow. And when the vessels become very narrow, the flow velocity will increase within the blood vessels in the brain. And so initially, when the ICP begins to rise, the ICP rises slowly, and to begin with, it rises above the diastolic velocity. At the same time, the ICP will still be lower than the systolic pressure. So the ICP will be higher than the diastolic pressure, but still lower than the systolic pressure. And when that happens, you see a transcranial Doppler waveform like this, which is a systolic spike. There is very little or no diastolic flow. That's because the intracranial pressure has risen above the diastolic pressure. Then what happens next? The ICP goes on rising. It rises so much that not only the diastolic flow ceases, you might get a reversal of flow during diastole, as you see here. So that's systolic flow. Because ICP is so high, what essentially happens is blood flows into the brain during systole and it just flows back in diastole. So that's when you get a reversal of flow with a systolic spike and a reverse diastolic flow. Again, one of our patients who became brain dead due to a massive hemispheric stroke. And this is what we got when we insunated him. There was reversal of diastolic flow, which suggested brainstem death. So this is the progression of changes that you would see when the ICP rises to a point which results in brain death. That's fairly normal. And as the ICP rises, the intracranial pressure rises above the diastolic pressure, giving rise to peaked systolic, purely systolic waveforms with very little diastolic flow. And then a situation arises wherein the diastolic pressure will be overwhelmed by the extremely high intracranial pressure, and that's when you get a systolic flow, but during diastole, the flow reverses. Essentially, blood flows in and out of the brain during systole and diastole without really perfusing brain tissue, which is equivalent to brain death. Now, you come across patients in your ICU who may have raised intracranial pressure due to several different reasons. This may be because of massive stroke, or maybe because of severe traumatic brain injury. Ideally, you should measure intracranial pressure invasively in patients who are intubated, sedated, very often paralyzed, because there is very little that you can go by in terms of clinical assessment. When they are deeply sedated and when they are paralyzed, you can only go by the pupil size. And as we all know, the pupil size will change, or the pupil becomes dilated only in the very terminal stages of raised intracranial pressure, when you have already missed the boat and there is very little that you can do to salvage the patient in terms of doing a decompressive craniectomy or any other measure. So it's extremely important to be able to monitor the brain. As I mentioned, invasive intracranial pressure measurement is the gold standard, but in many institutes, we may not have that facility. CT scans are okay, but clearly you can't do several CT scans during the day, which is again impracticable. So that's when ultrasonography by the bedside becomes a very handy instrument to assess your patient, to look for increasing intracranial pressure. So what's the basic principle behind assessment of intracranial pressure? You essentially measure the diameter of the optic nerve sheath. The optic nerve is actually a continuation of the brain, and all the meningeal layers of the brain are contiguous with the optic nerve sheath as well. So when the intracranial pressure rises, essentially the subarachnoid pressure also rises, and that results in dilatation of the optic nerve sheath. And the widest part of the optic nerve sheath is about 3 millimeters behind the globe, and that's where you seek the maximum width as a reflection of raised intracranial pressure. This, of course, is an MRI picture, but that's essentially what you check for when you do bedside ultrasonography. So how do you do it? What kind of probe do you use? A linear probe of high frequency, 12 megahertz, as you can see in this case, is placed transversely over the eye. Very important to apply a liberal quantity of jelly to make sure that you don't apply too much pressure and you don't do any damage to the eye. The probe marker should point to the right of the patient. And when you place the probe like this, what do you find? That's anatomy that you look for: the anterior chamber, vitreous, followed by the optic nerve sheath, which essentially appears as a hypoechoic streak behind the posterior aspect of the globe. Now, how do you measure? Where exactly do you measure? You measure the diameter of the optic nerve sheath 3 millimeters behind the posterior edge of the globe. And that's what the measurement is in this case. So when you measure, it's very important, as I mentioned, to get the distance right, 3 millimeters behind the posterior edge of the globe. And you measure, very importantly, from the outermost point to the outermost point, one side to the other. If you see, there is a very intensely hypoechoic streak here, which is the optic nerve sheath. And surrounding it, that's optic nerve, and surrounding it is the optic nerve sheath. So you need to essentially include the optic nerve sheath in your measurement. That's why you measure from the outermost point to the outermost point, from one side to the other. In this case, you can see that distance is 0.66 centimeters or 6.6 millimeters, which is high, suggesting that the intracranial pressure may be high in this patient. So what are the cutoff points to suggest raised ICP? Less than 5 millimeters diameter is considered to be normal. 5 to 6 millimeters optic nerve sheath diameter is borderline, and more than 6 centimeters suggests high intracranial pressure. Also of interest for the bedside ultrasonographer who is trying to evaluate the neurological state of his patient is to look at the carotid artery, particularly in patients with stroke. You may find a very thick plaque, as you see here, which is almost completely obstructing the blood flow. Or on the transverse view, you may be able to see the plaque like this. Or very often you may see a clot sitting in the extracranial internal carotid artery, as you see here, with very compromised blood flow around the clot. So these are obvious findings in patients with stroke, which may be of crucial importance in the assessment of patients with major hemispheric strokes. And when you do a decompressive craniectomy in your patient, it may be no longer required to move him up and down for CT all the time, because once the skull is out, you have a major window of opportunity here. With the ultrasound probe, you can get near CT quality images because that part of the skull is out. This again is one of our patients in whom we did a decompressive craniectomy for an intracranial hemorrhage. The skull is out on this side, so you can see the forks very clearly. You see the lateral ventricle is squashed on this side because of the lesion on this side, and it is fairly normal or dilated on the other side. So if your patient has had a decompressive craniectomy, it's a great opportunity to look at the brain through the window offered by the decompressive craniectomy to look deep into the brain. Again, in a patient with a decompressive craniectomy, there is a hematoma sitting there, which is clearly seen on the ultrasound. Not unusual is a patient like this. After major facial trauma, there may be coexisting traumatic brain injury as well. But because of extreme lid edema, the eyes may remain closed. You may not be able to open the eye to look at the pupils to assess this patient. What do you do in this situation? Can ultrasound be of help? The answer is yes. So what you do is you place a linear probe after applying plenty of jelly onto the eye, the pupil of which you need to look at, and then you shine a light on the opposite eye and essentially look for a consensual pupillary reaction on this side. And you can very easily see the pupil constrict with the light on the opposite side through a consensual reaction. In fact, this is one of the very useful interventions that I have come across in patients with severe lid edema, so much so that you cannot open the eye to look at the pupils. Ultrasonography in neurological assessment is a very important tool in the hands of the experienced intensivist by the bedside. It helps in several different ways. Detection of vasospasm early in case of subarachnoid hemorrhage is very important and easily done at the bedside by measuring the mean flow velocities. A velocity of more than 120 centimeters per second suggests possible vasospasm. Transcranial Doppler is an important tool in the diagnosis of brain death, especially in patients in whom conventional assessment may not be possible. What do you look for? You look for spiky systolic flow and reversal of diastolic flow. Raised intracranial pressure in patients in whom you have no access to invasive monitoring can be done by measuring the optic nerve sheath diameter, 3 millimeters behind the posterior edge of the globe, and a diameter of More than 5 millimeters is highly suspicious of raised intracranial pressure. In patients with stroke, you may look at the extracranial internal carotid arteries for possible plaques as well as clots. And you can even look at the middle cerebral artery to look at the perfusion there. If your patient has had a decompressive craniectomy, it offers a great opportunity for you to look at the brain through the craniectomy window. You may not need to do CT scans every so often to look at the brain. And when you cannot open the eyes because of lid edema, pupillary assessment can be done very easily using ultrasound. Thanks very much for listening. Thank you all.
Good morning, everyone. I am Dr. Amol from Tata Memorial Center, Mumbai, and I am talking
A very good afternoon, dear friends. Now we'll be discussing about a topic which is not a routine point of care ultrasound, but nevertheless is an important topic to understand how the various tissues in our body look like, and how we can incorporate point of care ultrasound to examine soft tissue and bones and look for abnormalities in the form of fractures, hematomas, abscesses, cellulitis, so on and so forth. So the various probes that we use for examining this musculoskeletal system, we have to have a wide variety of probes depending on which structure we wish to see and with what detail we would like to see those structures. For example, if you have a very small splinter of glass stuck to your pulp of your finger, then obviously we'll need a very small footprint probe with a very extremely high frequency so that we can see that structure in detail. On the other hand, if you want to look at deeper structures like bone, then we might have to select a larger probe with a low frequency so that we can go up to that amount of depth and see that structure properly. Now, the various structures on ultrasound, normal structures on ultrasound, have classical appearances. The epidermis and dermis appears hyperechoic or bright. The hypodermis, the fat, the subcutaneous tissue, will appear hypoechoic with hyperechoic fibrous septa between the individual flat globules. The tendons will appear hyperechoic with a fiber-like ecotexture. Similarly, about fibrocartilage, which is also equally dense, so they're going to appear hyperechoic. Dense structure like bone, which have high calcium content, or structures which have high calcium content, will have hyperechoic lining followed by a posterior acoustic shadowing or darkness beneath that. So you just see the surface of the bone and a dark shadow beneath that. Hyaline cartilage, on the other hand, is hypoechoic and uniform. The reason why it's hypoechoic or dark is because it has a high quantity of water in it. So if you remember the cartilage which you see in your neck, the individual tracheal rings all appear dark because they had high water content in it. Likewise, fibrocartilage will appear hyperechoic because they are dense, and that's the reason why they appear more brighter. Peripheral nerves, the nerve fascicles are hypoechoic with surrounding hypoechoic connective tissue, and the lymph nodes, which are there in the body, will appear as an hypoechoic oval mass with a central echogenicity. So this is what I was saying, the epidermis and dermis appearing brighter, relatively brighter, so hyperechoic. The fat appearing hypoechoic with a few strands. The muscles have a classical pattern, which we'll discuss shortly. The fascia, so the denser the tissue, the more brighter the tissue looks, in a nutshell. So how do muscles appear? The normal appearance of a muscle will depend on how we orient our probe across the muscle. If you're going to be placing the probe along your biceps, along the length of the biceps, or in the longitudinal orientation, you're going to be seeing it like a feather on or a leaves or veins on a leaf pattern, like you see a banana leaf. That's how it looks like. On the other hand, if we cut it across transversely, it will appear as a starry night pattern. The normal appearance of a tendon. Now remember, tendons are the ends of muscles when it gets attached to bone. So all the fibers are sort of condensed and tightly together. So in the longitudinal appearance, they're going to appear as fibrillar appearance, whereas in a transverse, they're going to appear as a broom end pattern, or the end of your broomstick, which has this individual fascicles inside it. So that's how it appears in a cut section of a tendon. The normal the ligament will appear similar to a tendon, but they are both dense fibrous tissue. A ligament attaches bone to bone, while a tendon attaches a muscle to bone. So obviously in a longitudinal, it's going to appear fibrillar, and whereas in the transverse, it's going to appear as a broom end. So what is a ligament and what is a tendon? You can very well differentiate by seeing from where it is arising. If it is a continuity of a muscle, then it's obviously it's a tendon. If it is starting from one bone and ending on to another bone, then it's a ligament. So for a detailed understanding of sonography of your musculoskeletal system, you need to have a detailed understanding of the anatomy of the structure which you're trying to see with the ultrasound probe. So you should know at least which ligament lies where, which muscle lies where, and then only you can understand this is how it looks like in a normal appearance, or something is abnormal about it. The normal appearance of a bone, as I said, was a hyperechoic line with a dark acoustic shadowing beneath that. Hyaline cartilage will appear hypoechoic because of its water content. And here you can see the hyaline cartilage, which is just totally outlining the surface of the bone, right? And the important thing is that it should not be confused with an effusion, because effusion is also fluid. It's going to appear dark. So that's where the knowledge of anatomy comes into the picture. And unlike an effusion, which will possibly collect in a form of as water collects, being maximum in that one area of depth and becoming thinner and thinner on both sides, the hyaline cartilage is, you see, notice it's uniform throughout the curvature of the bone. So that's how it makes a difference, that this is probably a uniform structure which is curved along the length of the bone and is not fluid. The normal appearance of the nerve, here you can make out a honeycomb pattern. This is the normal appearance of your median nerve, as you can see here. And on a transverse, you can see the individual honeycomb kind of pattern. And how do we differentiate between the nerve and the surrounding tendons of your fingers is by moving the fingers. And you can see that the rest of the tendons, which also has a broom end pattern, will move, while the nerve does not move at all. So obviously it's a nerve which remains static while the rest of the individual tendons will move. So that's how you differentiate between the median nerve and the individual tendons of the muscles of the forearm, which are attached to the hand. The lymph node, as I mentioned, hypoechoic with a bright hyperechoic hilum. And when you put a color Doppler, you can see a vascularity, a flow. Now, one may venture to say normal lymph nodes are usually oval in shape, and they have a preserved hyperechogenicity in the center with this vascularity. On the other hand, malignant lymph nodes lose this oval shape. They become more rounded. They start to invaginate into surrounding tissues. They invaginate into surrounding vessels, and they may all be clustered together. So that's one way you can sort of venture a guess whether the lymph node is possibly normal or pathological, but obviously you can't say it for certainty. Coming to the acute traumatic pathology of bones. Now it's very relatively simple to just simply follow the bone along the entirety of its length using a probe, as you can see in the first picture. So you just follow the bone along its longitudinal axis and you look for some kind of defect in the continuity. And this is probably the safest and the easiest method to do. But what one should remember is that the depth of the bone may be different in different areas. So it may be, for example, if you talk about your femur, it is very deep in the thigh, and when it comes towards the knee, it becomes more and more superficial. On the other hand, the tibia is superficial throughout. So that's how we have to adjust the depth accordingly, so that we are continuously following the cortex of the bone and looking for some defect in this continuity. So when we come across a fracture, it comes as a discontinuity in the cortex. As you can see here, the white cortex is disrupted and the two edges are overriding each other. Sometimes around the edges which are overriding, you can also see an hypoechoic collection, which is basically the callus or the hematoma, which is formed around the broken bones. So simply you just keep your probe along the bone, see for the bright hyperechoic surface cortex of the bone and the dark shadow beneath. So you know that this is bone, and you trace it along the length and look for some discontinuity somewhere in the entire length. Now, ultrasound becomes even more essential when you talk about long bones and bones of your small bones of your hands, where it's sometimes very difficult on an X-ray to catch small fractures, but on an ultrasound, you can actually see the discontinuity in the bones. In pediatrics, the pediatric skull is relatively more flexible. At the same time, it's not calcified as yet. So you can actually make out the outer table as well as the inner table. So any fractures here, the sensitivity is almost as good as that of a CT scan. So for pediatric fractures, skull fractures, the sensitivity, as you can see here, is 88 to 97% specificity is there. So it's almost equivalent to that of a CT. So that's how we can say that ultrasound is that useful in pediatric skull fractures. Now the sternum is a bone which is quite often injured in blunt trauma to the chest, and at times injured after a prolonged and aggressive CPR as well. So this can present with tenderness over the anterior part of the chest. So how we can scan it is by placing the probe along the length of the sternum and tracing it from top to bottom. Now with regards to sternum, we should understand that there are three distinct parts of this bone. The first part being the manubrium, the topmost part. Then comes a manubriosternal junction, where there's a discontinuity, which is natural. And then comes the entire sternal body as one continuous bone. And there's one more discontinuity followed by a xiphoid process. So a manubrium, a sternal body, and a xiphoid process. So these are three parts of the sternum. And there are two natural discontinuities in this sternal bone. One is at the manubriosternal joint and one is at the sternal xiphoid junction. So short of these two breaks in the cortex, if there's any other break or breach in the cortex anywhere along the length of the sternal bone, then we know that there is a fracture of the sternum. The same thing can be also seen in a transverse section, where we can turn the probe transversely and scan the entire sternum from top to bottom. Now, with regards to rib fractures, ultrasound is very, very useful when it comes to rib fractures, because on an X-ray, sometimes rib fractures are difficult to make out. Why? Because especially the ribs are most prone to injury at the angle of the ribs, and there on an X-ray, sometimes it's very difficult to make out whether it's a fracture or not. At least on an AP or a PA film, it's actually difficult to make out. But with an ultrasound, you can actually trace individual ribs right from the manubriosternal, from the sternum junction, the costochondral area, and the entirety of the ribs from anterior to posterior. So anytime you see a discontinuity or a breach in the continuity of the rib with overriding of segments, you know that there's a rib fracture. The easiest way is obviously to ask the patient where the maximum tenderness is, and then you trace it at least 2-3 centimeters away from it, and then trace it slowly towards the point of maximum tenderness and see for a breach or a discontinuity, and progress 2-3 centimeters beyond, so that you know what exactly is the amount of injury which is there. So in conclusion, ultrasound has surprising capability in diagnosing several types of fractures and usually plays a complementary role in diagnostic imaging. So it is effectively just adds on to your diagnostic imaging, which is X-rays. In emergency, ultrasounds are only limited to specific indication with well-known findings in order to minimize mistakes and not to waste any time. So if you are only those indications like fractures, which you can see, rib fractures or fractures of long bones, which you can see on ultrasound, that you can obviously use to reconfirm your findings. Short of that, we should not try to look for small things which may not be very, very significant. And obviously, it requires a good knowledge of skeletal anatomy to understand whether it's a fracture or a natural joint or whatever it is. Now, coming to muscles and tendons. Now, I told you a muscle in this cut section will appear like along the length will appear in a leaf on a vein pattern. right? And on a cut section, it will appear like a starry sky pattern transversely. So when you have a hematoma, the individual muscle fibers are sort of separated out with streaks of blood. Blood is dark in color, so you get black streaks within the body of the muscle. When you have elongation and tear, so you see the same thing along the length. When you place it along the length, you see black streak along the leaves on a vein pattern. You see black streaks along that. So elongation and intramuscular hematoma can be seen. It should always be compared with the contralateral normal side, apparently normal side, so that you know that this is normal and this is abnormal. And most importantly, you should understand that it is useful to follow real time the pathology as it comes. You know that intramuscular hematoma can actually increase in size. It's not as if it comes and it just stays there. It can actually increase in size. And the findings may be dynamic in the sense that it changes its character over a period of time. So when we have a muscle distraction with a wide hematoma, you can see a large collection within the belly of the muscle, which is hypoechoic. You can actually measure, and the normal pattern of the muscle is lost, and the collection is irregular and anechoic to hypoechoic. When you have a wide hematoma, and this in the initial phase may be liquefied. So since there's a hematoma, it is partially liquid. So when you compress the muscle with your probe, you can actually feel this collection reducing in size or dispersing sidewards. And when you release it, it again comes back. So this dynamicity or probe-related compression says that it's probably a fresh hematoma and not an older one, or the patient is on some kind of anticoagulation because of which the blood hasn't clotted as yet. So that you can actually make out whether it is an early phase or a later phase of the hematoma. Similarly, you can see rupture of the muscles. You can see infiltration of the muscle with anechoic streaks. When we have an Achilles tendon rupture, you can see that this is the fibrillar pattern of the normal Achilles tendon. And when it is ruptured, you can see a disruption in the fibrillar pattern. Here you can see that it's totally, instead of appearing absolutely straight, it's totally broken down with hemorrhages and a ruptured portion. And you can see a tear right here. The patellar tendon, you obviously place a pillow or a fold beneath your knee so that the knee is slightly flexed. And then you follow the patellar tendon from its insertion onto the patella onto the tibia. And there you can actually see the normal patellar tendon looking like this. And when it's ruptured, you see infiltration by hypoechoic material or blood into that area. So the logic of emergency ultrasound is to basically provide a yes or no answer to specific diagnostic question in order to complete the clinical evaluation. The most common indication being tendinous tear, muscle distraction, and hematomas. And what we do find in all of these is basically structural disarrangement. So normal structure is destroyed, it's separated, and there is intra or perimuscular tendinous collections. They are there, and they are interrupted fibers with or without retraction, and possibly there may be some kind of dynamicity in the sense that whenever you compress it, the hematoma may change its shape based on whether it's fluid or not. So the key message is that you always compare it with the contralateral side. The contralateral side, so you've got two limbs. So if one limb is injured, the other limb can be used as the control arm, where you see whether that what appears to be normal, and you can see what appears to be abnormal here. Only look for major lesions. Always correlate clinical and ultrasound finding. Just a chance finding may not matter at all, but if it's correlates to the clinical picture, it has more value. And it has short time control. Remember that time is important. In case you just had an injury, things take time to develop. So you won't find ultrasound findings immediately. You may find it over a period of minutes to hours. For example, if you have an injury, it takes some time for the swelling to come. So that much time it will take for the ultrasound findings to come as well. And try to reconfirm all these findings on radiology as soon as possible. Coming to detection and localization of a foreign body. Now, foreign bodies sometimes get into your limbs, your hands, your feet when you step on this, and sometimes they're so small and they are non-radio opaque. So it's very difficult to pick up on a routine X-ray. At the same time, they can cause a lot of pain and discomfort. But with an ultrasound, you can actually see even the smallest of foreign bodies, maybe a few millimeters, pieces of glass, pieces of wood, pieces of plastic. which may get into you. Obviously, stone and metal objects can also be seen. So what we need to do is obviously we take the preset, we take the high frequency probe with a small footprint. They are specialized probes who are ultra high frequency with even smaller footprints, as small as this, so that you can easily fit up on top of your digit. And you have to use a sterile technique because that's an area where some injury has occurred. So you apply a gel-filled glove or pad, and then you place it on top of that and try to interrogate it in two planes, longitudinal and transverse. Now, it goes with the premise that any foreign body, whenever it enters into the body, will produce some kind of tissue reaction around it. The tissue reaction around it is usually in the form of some amount of fluid leakage. And this fluid leakage will produce a kind of a halo around the foreign body. So here you can see a small 3 millimeter small stone, which has got embedded into the soft tissue, and it has created a halo because of the tissue reaction, and you can actually make it out very easily. The same thing on an X-ray, you can see it here, the stone. Now this was fortunately, this was radio opaque. Radiolucent objects can also be seen the same way because they produce a similar kind of reaction. At the limitations of foreign body detection is that obviously the operator needs to be experienced. The size and depth of the foreign body, it may be sometimes so small that it cannot even be picked on an ultrasound. And it may be so deep that sometimes clear images cannot be obtained because the high frequency probe can only penetrate up to a certain depth. And more importantly, if the object is right on top of the bone, then it will be difficult to pick it up because an hyperechoic object on top of an hyperechoic surface is going to be difficult to pick up. And in case the reaction produces some amount of infection and there's air also within the injury, then it's even more difficult to pick up the nature of the body, foreign body inside, because air will obscure all the findings. So you'll get something like a localized subcutaneous emphysema in one single area in the subcutaneous tissue. So that could actually tell you that there is something lying there which cannot be seen because of the air which is around it. The air could be because of communication directly to the skin, to the atmosphere, or the air could be there because of some bacterial infection in that place, which has led to anaerobic bacterial infection, which lead to production of air. Coming to abscesses, abscesses are hypoechoic collections. Basically, they're hypoechoic in nature, and they are heterogeneous. Heterogeneous is that they are not uniformly hypoechoic, or in nature they have partially liquefied, partially solid, and there is posterior acoustic enhancement, meaning the lower margin of the abscess is brighter as compared to the entire content. There is a possibility of gas inside. The biggest differential diagnosis is differentiating between an abscess and a hematoma. The difference is that the abscess is hypervascular and the hematoma is avascular. There's a reason because an abscess will bring about a profound tissue response, leads to increased amount of blood flow into that area. There'll be vasodilatation of capillaries around it. So whenever you put a color around an abscess, there'll be a lot of blood flow around the abscess, which is heading into the abscess. On the other hand, a hematoma is totally avascular. Right. Cellulitis is subcutaneous collection of fluid. So when there's subcutaneous collection of fluid, the fluid will accumulate it into the skin and subcutaneous tissue. So what's going to do? It's basically going to separate out the individual flat globules into different areas. So you get something which looks like cobblestone edema. So the individual flat globules have been separated out by fluid, or the edema fluid. So it leads to what the classical picture of cobblestone edema. So that's how cellulitis looks like to you. Superficial phlebitis is basically, phlebitis means that there's inflammation of the veins, of the superficial veins. So the veins become taut cord-like. So when you see the vein may appear very big in lumen size, but when you try to press it, there is no compression. It is totally filled up with a clot or thrombosed material. So this is how superficial phlebitis looks like on an ultrasound. A Baker's cyst rupture is sometimes which you can find in a chance finding, especially in a patient who presents with acute onset knee pain. So if you are looking for what is the cause of the acute onset knee pain, the normal Baker's cyst looks like this, small swan shaped with a body like this. When it ruptures, there is a sudden large increase in size. It is seen posteriorly behind your patella. So it's seen there, and there you can actually make out echogenic material within this collection, which is basically high cholesterol rich fluid which gets collected when the Baker's cyst ruptures. Now coming to a different aspect, how do we do the sonography of your spine, and how does it help you in doing successful lumbar punctures where it is difficult to perform lumbar punctures because of either deformity or because of extreme obesity or because you're just simply not able to find out where the midline is. So here, the ultrasound can come of some use, and I'll tell you how. So this is the anatomy of the lumbar spine. So you know how the spine is divided into is basically divided from, if you start from outwards, it has transverse processes. These transverse processes then come together and there are laminas, as you can see. Then comes first transverse articular processes, laminas, then comes the spinous process, and between the spinous process is your interspinous area. So from out to in, transverse process, articular processes, lamina, spinous process. So that's how it is, and that's exactly what we're going to be seeing on an ultrasound as well. So how is it useful to us? It is useful because it helps us to facilitate lumbar puncture, spinal and epidural anesthesia by providing some amount of information. And this information is that it will tell you exactly the interspace where the puncture should be performed, which is the best interspace which is available, which is the ideal insertion point, what should be the angle of your needle, how deep is the skin from the epidural space or the subarachnoid space, and at the same time identified abnormalities such as scoliosis. So what should be the position of the patient when we do this? It's either lateral decubitus or sitting position, the same way as we're going to do a lumbar puncture. The probe which we use is the large curvilinear low frequency probe. Why? Because it has got a larger field of vision. It has got a deeper depth penetration, and we are obviously looking at difficult spines where we can't even make out spinous processes. That spine is likely to be at significant depth. So the initial depth setting should be around 7 to 8 centimeters, which is beyond what we can normally get with a linear probe. So we have to adjust the depth, focus, and gain settings of the ultrasound machine so that we can see the spinous, the entirety of the spine, the various aspects of the spine in different areas. So what is most important is pattern recognition. You may remember that we are looking at bones and not simple bones. We are looking at a very complex bone, which has got a few projections, something up, something on the side, something straight out. And obviously the bones are do not allow ultrasound beams to go through. And there's overlap between the spinous processes. So obviously we have to direct a beam in such a way that we can look between the two spinous processes. So for that, we need to understand how the anatomy of the spine is and how it appears, at least on ultrasound. So just a brief revision, the bone will appear white and with a dark shadow beneath. The ligaments will appear white, but less as dense as bone. And the flat and the fluid are dark, hypoechoic. So there are a few important anatomical planes or sonographic planes in which we try to orient our probe and direct the beam. So the three basic orientations of the ultrasound probe and beam are: the first, the paramedian sagittal orientation, where the beam is oriented in the sagittal plane lateral to the midline. So we start away from the midline and we move towards the midline. Why we do this is because we know that they are the transverse processes, which are the most lateral structures, appear in a specific way. And as we move towards inwards, they convert into the articular processes, then the lamina, and finally the interspinous place. So we have an orientation of where we are heading from lateral to medial. So we know which is medial, which is lateral. So if you place a probe and you find the transverse process, we know from here the movement will start inwards. So that's first positioning is a paramedian sagittal plane. Then comes to the paramedian sagittal oblique plane, where we have managed to slowly shift our probe right to the midline, and then we are tilting it in such a way so that it can look inside the median plane. And transverse is when we turn our probe transversely and we orient it in between the interspinous spaces. So I will talk a bit more about each. So the entire interrogation of the spine will occur through 5 basic views. The first, the transverse process view. So as I said, we start placing the probe longitudinally from lateral and move towards medial. When we are moving from lateral to medial in a longitudinal orientation, we get what's called the parasagittal transverse process view. So this is 3 to 4 centimeters lateral to the midline. So we have the sacrum as a margin because sacrum is a continuous bone, right? So we have placed a probe just on top of the sacrum. We know that it's a continuous bone. We start moving upward from the sacrum. Once we have moved up from the sacrum, the lumbar vertebrae and their transverse processes start. So the transverse processes, since they are all spread out, will appear when we have placed a probe like this, will appear like individual bright echoic line followed by dark shadow, bright echoic line followed by dark shadow, bright echoic line followed by dark shadow. So these are individual transverse processes, and the area between the transverse process is comprised of the erector spinae muscle. So this appearance, which you see, 3 dark shadows appear like a trident, Trishul. So this is the first sign which you try to look for. This tells you that my probe is placed across my transverse process. If you have started from the sacrum upwards, the lowermost transverse process, suppose this was a sacrum, the lowermost transverse process will be the transverse process of L5. This will be L4. This will be L3. So we know now we have got an orientation that my probe is parasagittal in the longitudinal plane and it's on my transverse process. And I have to move now towards the midline. So the trident sign, remember, it's a finger-like appearance of your transverse processes. So the first view is the trident sign. Next, from the transverse process, we now move, keeping the probe or longitudinal, we move more towards the midline. And when we move towards the midline, what happens is that instead of separation between the bone, now we see a continuity of the bone. You see, there's a continuity of the bone from above to below. So here, the bone, instead of being separated, now looks like a continuous undulating hump. So this like our undulating hump. Initially, they were separate, 3 separate things. As you can see here, 3 separate. From here, it has become an undulating hump, one continuous hyperechoic line which seems to be undulating. So this hyperechoic line, undulating line, is because of the bone here, which is continuous. There is no there is no separation by erector spinae muscles. So here, when we have placed a probe just close to the midline, beyond, more closer than the transverse process, we come across the articular process. So here it comes like a camel hump. So the important thing, landmarks are rounded humps of the facet joint between the superior and inferior articular processes. And mind you, this is more superficial than the transverse processes. Transverse process, if they were at 8 centimeters, this may appear around 6 centimeters. So it tells you that now you have made a transition from the transverse process to a relatively superficial structure, which is the articular process. Next, once we have reached the articular process, now what we do is we just tilt a probe towards the midline, right? For example, when you've kept it here and we tilt our probe slightly towards the midline, we can just look into the spinal canal, like a paramedian kind of a view. So here, when we tilt the probe, we get, instead of an undulating pattern, we get something more like a sawtoothed kind of pattern. As you can see, straight, sawtooth, straight, sawtooth, straight, sawtooth. And when you're tilting inside, you can actually look into the interlaminar space. So this area with this dark fluid collection is basically your intrathecal space. The bright line here is the posterior dura, and the anterior part is the anterior complex. The area above the bright line is epidural space, and this is the CSF which is flowing inside the thecal sac. So you can make out from a paramedian view how exactly the entire spinal canal looks like. So here you have placed a probe and then tilted it slightly, right? And we have tilted it. Now, once we have managed to find the midline, see, we have come close to the midline. We have just stopped next to the parasagittal area and tilted. We have understood that here is a spinal canal. We know it. Now, the probe is rotated by 90 degrees into a transverse orientation and then centered along the midline or the mid-neuroaxial axis. So here we are going to be seeing the individual spinous processes, right? The spinous process will appear in the form of a hyperechoic rim followed by a triangular shadow. So when we place it like this, the image will appear a rim followed by a triangular acoustic shadow. Right? So now we have seen the midline. We have seen how the spinous process looks like. Now, how do we see between the space? We just simply tilt our probe, right? Slightly cephaloid. When we tilt our probe, we can see between the interspinous spaces. As you can see here, the probe is looking, we just tilt it slightly so that it can look directly between the interspinous spaces. So when we do that, we get this kind of an appearance. This is what's called the anchor appearance, an anchor-like shape. And we have the ligamentum flavum, which is posteriorly, and the vertebral body, which is anteriorly, and between both of them, we have the thecal sac. On both ends of this anchor, we have the facet joint, one here and the other facet joint. And mind you, both the facet joints should be at the same level, which says that there is no scoliosis. In case one facet is above another, there is some rotation of the spine, because of which the facets are not exactly mirror reflection of each other. So if you have to draw a line between these two, from transecting it from the middle, this end and this end should look like mirror reflections of each other. That says that the spine is exactly straight and not twisted or turned or scoliotic or whatever. So effectively, what I'm trying to tell you is that the views from lateral to medial transverse process is the trident sign, followed by the camel humps, followed by the sawtooth sign, followed by an parasagittal oblique view, which shows you the dura and the anterior complex. And once you have seen that, we turn the probe transversely and we look at this, which looks like the anchor, which is, and tilt the probe and we look at the interspinous spaces. So we have done that. We have understood how to see between the intercostal spaces. So how do you know which space is which is L5, S1, which is L4, 5, which is L2, 3, and so on. So obviously, when we start from the parasagittal view, we start from the sacrum upwards. So we know that the first transverse process is the L5. So if we go medially, that will be the body of L5. And then we tilt medially, that is the space between the L5, S1. Then L4, 5, L3, 4, L2, 3, and so on. And you can mark it individually. Coming to the needle insertion. Now that we have marked which space is what, so we have a map on the back, right? Now, we know that we have to somehow insert the needle in between these spaces. We know where the vertebrae are, where the midline is. Now we have to insert the needle. So how we do it is basically, we have placed the probe, we have tilted the probe so that we can see between the intercostal space. Now we mark 2 points, one from the middle of the probe, right from the middle of the probe anteriorly, and one exactly in the middle of the probe on the lateral side. And we draw a line between both of this. And where this line intersects is the area where we're going to insert the needle. The needle will be inserted to a depth, which is a depth from the skin till the space, right? And at an angle, which was required for this probe to be tilted to see the space between the two spinous processes. So suppose you had to tilt your probe by, say, around 30 degrees or so, and you have seen the depth is 6 centimeters. So at this midpoint, where the two lines join, we're going to be inserting the needle up to a distance of 6 centimeters with an angulation of 30 degrees, and you will enter the spinal canal. So this is not a real-time thing, rather it is a marking technique, a static kind of a technique, but it will help, especially when you have no idea where the back, where the midline of the spine is lying and which part is what. So in those cases, it can really help you, tell you exactly at what depth the spine lies, where the spine exactly is lying, and what depth you should insert the needle and how much you should go with the needle. So instead of going blindly, you can be guided, and to quite an extent, it will help you how to do difficult lumbar punctures. It is also used to identify atypical sonograms where scoliotic spine, as I said, will not present as mirror image. The two articular and transverse processes, the anchors, the two part of the anchor which I mentioned when we keep it in a transverse position and tilt your probe, they may not be mirror image of each other. One side may appear higher than the other. If they appear not exactly as mirror image, then probably the spine is rotated. So this is an example of an atypical sonograph. This is a classical one where this is normal, where you can see this side and this side appears same if we draw a line through the middle. So this is the articular process on one side, the articular process on one side, they're on the same level. On the other hand, the articular process of this side and the articular process of this side is at a different level. So obviously they are not a mirror reflection, there's a scoliotic spine. So my friends, I would stop it here. And I hope that this topic, although it's not a part of your normal point of care course, which involves a head-to-toe examination of deranged physiology, will still be of use to you because you have an entire musculoskeletal structure as you try to move your probe around the body. So you should know what structure is what, and what else can we do with the probe that's on the bedside of the patient, especially if the patient comes with trauma or foreign bodies or some kind of injuries. There it can come of a lot of use to you. Thank you.
So good afternoon all. Now, after looking at various aspects of ultrasound in critical care, understanding how to assess from head to toe, so let us just revise as what we learned in last 2 days. So this is an interactive case scenario session where I would be showing certain interesting images, certain images which you must have seen in the previous talks, and we will just try to revise as in, do you actually understood the message that we tried to give. So let us start with the slideshow. Anybody? So we very well understand this image. Now this is the vocal cord when we do the airway ultrasound, and when we have an image which is very similar to the vocal cords but smaller in size, this is called as pseudo trachea or a double trachea sign, classical for an esophageal intubation. So once you are putting an endotracheal tube into the esophagus, the ultrasound will start showing almost a similar image as what you see as the trachea, where a tracheal ring and an air mucosa interface will be seen. So this is a classical example of esophageal intubation. So whenever you encounter such an image, ask the operator to take out the endotracheal tube because he has gone into the wrong space. Then try to look at both the lung images. So these are pleura. We have seen this in the lung lecture. Now if you can try to clearly see the first image, this is the image that I am talking about. These vertical lines, these laser-like images, they are not moving to and fro. They are stagnant at one particular point. We are seeing it in the fast manner because probably the patient is tachycardic. Whereas if you try to see this pleural line, it is sliding. So there is a to and fro movement of the pleural line. So if somebody has to describe both the images, this is an immobile lung. Sliding is absent, lung pulse is present. So where will you find this? This you can have in an endobronchial intubation. So if your endotracheal tube has gone on the right side, this is the image that you will see on the right lung, because right lung is ventilating, it is contributing in ventilation, whereas the left lung has collapsed. So there won't be any lung sliding, only the lung pulse will be present. So this represents mobile lung, sliding is present, lung pulse is absent, and this is what we find in endobronchial intubation. Then this image. This is liver, and this is a structure which is looking very similar to liver, right? So this is actually what we'll hear about, hepatization of the lung. Where do we find this? We find this in consolidation. Another important sonographic sign which we see in consolidation. So a smooth superior margin and an irregular inferior margin, and we see that B lines are originating at various levels. So this is the pleural line, and this is a smooth surface which has actually stopped contributing in ventilation. So this area is consolidated, and this is still an aerated area that we are seeing below this white line, which is the pleural line. This is called as the shred sign. Again, very classical what we see in consolidation. The third sign that we see in consolidation, dynamic air bronchogram. The air is coming in and out. So with every phase of respiration, you will see the movement of air. If you want to classically find this sonographic sign, try to look in a post-operative patient who has been running fever, who is lying down for most of the post-operative days. So try to look at zone 5, zone 6, probably at the backside, where you will find the area is consolidated and you can have this sonographic finding. This is dynamic air bronchogram. Contrary to this, if you try to look at this image, the air is not moving in and out with phases of respiration. It is stuck at one point. So air is trapped inside the alveoli and it is not moving with respiration. So there is lung pulse. The pleura is not sliding. It is collapsed. There is a lot of anechoic fluid around it. So it is an effusion. So this is pushing the lung, and this is called as static air bronchogram, and this is what we see in atelectasis. So in consolidation, we see dynamic air bronchogram. In atelectasis, we see static air bronchogram. When we talk about ARDS, we say it's a non-homogeneous disease. So you will have areas of dense consolidation, mostly in dependent areas. You can find air bronchograms, you can have subpleural consolidation, and also you can have areas of relatively normal appearance. So when you talk about what is the status of lungs in ARDS, you will have first an inflammatory pulmonary edema lights in it. So there will be a lot of B lines, a rocket-like images will be there, or what we call as the laser show image will be there. Then there will be an alveolar collapse. This alveolar collapse will give rise to atelectasis, so we can start finding static air bronchograms. This will become patchy in nature and will form patchy consolidation. And end of the day, you will have all these patches coalescing together and they will form a basal dense consolidation. So this increases from top to bottom. So you will have this more in the dependent areas, whereas there will be, and similarly it corroborates with loss of aeration. So if you want to assess the lung aeration assessment, this can be semi-quantitatively assessed using the following ultrasound findings. And this is often in progression, as I said, that you will first have a normal pattern. Then these normal patterns will have multiple spaced B lines. So they will be far off B lines. These B lines will then start coalescing, and then you will have consolidation. And this will ultimately lead to loss of aeration. So as I said, you will have far spaced B lines. These B lines will increase in number, so they will start coalescing. Then you will have a lot of B lines, so you will actually not able to differentiate the number of B lines. They have all coalesced together, and finally this gives rise to a patchy consolidation like feature, or what we call as subpleural consolidation. So this is under the pleura, and this is subpleural consolidation, very, very classical and pathognomic of ARDS. And this is, as I said, subpleural consolidation. A smaller image is what is seen. So this is the pleural line. A lot of B lines are originating from it. And this is an irregular B line. So this area is consolidated. It's not contributing in respiration. And you will have multiple areas of subpleural consolidation whenever you are dealing with an ARDS patient. So this was a study where they looked at what is the use of sonography in assessing the recruitment in patients. And this was a pilot study, and they looked at the status of the utility of ultrasound whenever you are attempting recruitment in patients. Another way of assessing was that they wanted to look at the effect of PEEP-induced lung recruitment. And they added that it is a diagnostic tool. Ultrasound can be used as a diagnostic tool for assessing positive end expiratory pressure induced lung recruitment. Because it is non-invasive and easily repeatable at the bedside, it can be done n number of times, and it also allows close monitoring of any respiratory maneuvers which have been done to increase the lung aeration. So if you are giving a recruitment maneuver, you can attempt pre-recruitment, post-recruitment. You can look at the effect of recruitment. Is the collapsed lung opening up? Is there an increase in the saturation? You may also see disappearance of B lines or reduction in the number of B lines. So this is how, and you can do it n number of times. So basically, it's an excellent diagnostic and monitoring tool whenever it comes to recruitment. So they looked at certain scores, and this was called as lung re-aeration score. So you can have a quantification of the loss of aeration or a quantification of re-aeration. So 5 points were given when there was from a normal lung to a total consolidated or a collapsed lung. 3 points from normal lung to 2 B lines or 1 B line to a collapsed segment, and 1 point was given when normal to 1 B line, B1 to B2, and 2 B lines to a coalescent or collapsed lung. Similarly, the re-aeration score was given. This was published in AJR-CCM in 2011. So if we have to study here, now this is when the patient was receiving a PEEP of 5. You will see lot of B lines, probably coalesced in nature. Now, as the recruitment has been attempted by increasing the amount of PEEP, so from a PEEP of 5 to 15, we have seen there is a reduction in the B lines. So again, this is a re-aeration score is happening from lot of B lines to a minimal B line. So this is probably falling into category 3, and this is a monitoring as well as a diagnostic tool. So this tells us that this lung is recruitable. So if you are attempting recruitment maneuvers in such a patient, you will have benefit and rather than side effects. Then another example, this patient had lot of B lines, n number of B lines, probably coalesced in nature at certain areas. When you increase the PEEP from 5 to 15, these coalesced B lines became sparsely placed B lines. So here you can actually count the number of, in the second image, we can actually count the number of B lines which are there, whereas in the first image, that is not possible. Now, again, a PEEP of 5, so totally collapsed lung. This is all pleural effusion that is being seen, and this is looking like liver, a hepatized lung. So after increasing the PEEP, we can see some improvement in the lung architecture. The lung has opened up and it has started contributing in respiration. Now, you can also have a non-recruitable lung. So as I said, this is a diagnostic tool. So when the PEEP has been increased from 5 to 15, there has been no change in this particular area, which has a small subpleural consolidation and a coalesced and dense B line, which is originating from pleura going up to the base of the screen. So there has been no change in the lung status even after increasing the PEEP. So this is a non-recruitable area of the lung, and by just giving recruitment maneuver or increasing the PEEP is not going to help this patient. Rather, we will face more and more side effects. Then a collapsed lung. So if you look at this video, this looks like a totally collapsed lung looking likely, but now when you're attempting a re-aeration by giving recruitment maneuver, some amount of aeration has started to happen. We see few B lines started appearing. So this lung can be recruited. Now, after recruitment maneuver, we have started seeing this sliding of the lung. A lung pulse was present in the previous slide, where here we are seeing the lung sliding, which is happening, although there is some amount of effusion. Then after recruitment maneuvers, giving a little higher PEEP and waiting for around 8 to 10 hours, we see that almost the entire lung has opened up. It has started contributing in ventilation. We have started seeing the B line. So appearance of B lines is not bad after a totally collapsed lung. It tells us that the lung, that the pleura has that the lung has opened up, the pleural sliding has started, and we have started seeing the aeration. And this is post 24 hours, and the entire lung has aerated and it has opened up. So this was probably a collapsed segment which was lying and which opened up after recruitment. So if you want to sequentially see it, this was a totally collapsed lung looking like liver. You gave a recruitment maneuver, some amount of lung opened up. After certain hours, the lung, major part of the lung opened up, and almost 24 hours later, the entire lung opened up and it started contributing in ventilation. Now, this was a patient, which was before the proning was attempted. And if you can identify both these structures, liver and the lung, they look like the same structure, right? So this is a totally hepatized lung, or probably a collapsed segment, which is giving us an appearance of a consolidation. And after proning, if you can appreciate, you are seeing the pleura which is sliding, right? So this is the pleura which is sliding, and this tells us that this lung is recruitable, and this is 4 hours after the proning and attempting a PEEP of 10. The pleura has started sliding, so the lung has recruited. Now, almost 12 hours later, the entire lung has recruited, and we are seeing the sliding which has started happening, or the curtain sign which is coming and going. And again, a monitoring tool or a diagnostic tool. So before even attempting proning, if you are giving a recruitment maneuver, it tells us that the lung can be opened up. It guarantees that post proning, the patient will benefit from recruitment. So sequentially, if you see, this is the pre-proning ultrasound. Then 4 hours after proning, you started seeing some amount of sliding, and almost 12 hours after proning, a good amount of lung has opened up and it has started contributing in ventilation. Obviously, this patient will do better in proning. So this is a marker of increase in the aeration. Now, this was a patient who was post-transplant and was a little weak. He started retaining secretions and probably had a mucus plug which got fixed in, and he had a collapsed segment of the lung. And bronchoscopy was attempted, and post-bronchoscopy, NIV was given to open up the lung. So thick mucopurulent secretions were aspirated. And now we can see that with the help of both the procedures, the lung has started opening up, and we have started seeing some amount of B lines, or an irregular line, or what we call as the shred sign. There is some amount of sliding which is happening. So we have to understand that recruitment can be predicted or can be assessed with the help of an ultrasound. So once you are doing an ultrasound, sequentially do it. So once you have attempted a recruitment, try to assess the response of that recruitment. Now, this is the kind of heart of a patient. This is the IVC. The lungs are more or less clear. There is a good sliding which is happening, and there is some amount of free fluid which is present around the spleen or the splenorenal fossa. Patient is coming from a scenario of trauma. So this tells us that this patient, if I have to say, a hyperdynamic or an empty heart, a collapsing IVC, non-wet or a dry mobile lung, and fast positive. So this will tell us that this patient has hypovolemia. So try to look for the cause, resuscitate these patients with fluid and blood products. Now, a lung sliding, which is having A pattern lung sliding, no B lines. This is the heart, right side, left side. Now, if you can appreciate, right ventricle is bigger than the left ventricle. Even right atrium is bigger than the left atrium. The IVC is taut. There is no respiratory variability. And once you do a femoral ultrasound, you will see that there is a white echogenic material found in the femoral vein. So looking at this scenario, if you're trying to compile this scenario, a dry lung, mobile lung, and patient who is coming in hypotension and acute respiratory distress with a sliding lung. We are trying to rule out tension pneumothorax and even pulmonary edema because it's a dry lung and A pattern lung with right-sided dilated. This fits into massive pulmonary embolism as the cause of hypoxemia and hemodynamic instability. This is a patient of chronic kidney disease, now comes for dialysis, has hypotension during dialysis. You do an ultrasound and you do an cardiac ultrasound and you find this. So diastolic collapse of the right atrium, right ventricular collapse, massive amount of free fluid around the lung, and the IVC is fully taut. This is pericardial effusion leading to tamponade. So remember, all pericardial effusions are not causing pericardial tamponade. So pericardial tamponade is an echocardiographic finding. So if you start seeing the diastolic collapse of the atrium and the ventricle, you will understand that this is what pericardial tamponade will look like. So B lines, this is the left ventricle when you are doing the cardiac ultrasound, hardly any function of the left ventricle, lot of B lines, so wet lungs with these B lines and IVC is taut. So if this patient is coming in respiratory failure and you find these three things, so wet lung, poorly contracting left ventricle, non-collapsing IVC, this will tell us that this patient has left ventricular failure or what we call as a pump failure. So certainly more interesting images. Now, if you try to appreciate the left ventricle here, so this is looking like a dumbbell shape, right? If you can appreciate the image, this is dumbbell shaped heart, and this is a patient who can develop sudden tachycardia, hypotension in the post-operative period or after a stressful ICU stay, and this is what is called as stress cardiomyopathy or Takotsubo cardiomyopathy or apical ballooning syndrome. The apex which has to be pointed, it becomes ballooned out. So this is apical ballooning syndrome, and actually the management is symptomatic and try to remove the stress. If you go through this, there is hardly any contractility. So this is actually a CPR has been going on and there is no contractility, and asystole heart is what we can see here. There is no. So this helps us while you're doing a CPR. So when you're trying to check for the pulse in that 10-second window, put your ultrasound probe in the subcostal or a parasternal view and try to localize the causes of the arrest. So you can have a pulseless electrical activity or you can have any other finding which will tell us that probably this is the reason for the cardiac arrest. Almost similar image as the last one, lot of free fluid around the heart with collapse of the atrium, and this is massive pericardial effusion leading to pericardial tamponade. Yes. So what is this? Now this is Foley's catheter bulb, and this is free fluid above in the pelvic area. So what is it? So we are not trying to identify the free fluid. What we are trying to look at is the Foley's catheter bulb, which is visible. Here, a thrombus is visible in the internal jugular vein. A fixed, an attached thrombus is visible here. Similarly, a floating thrombus is visible in this IVC, in this IJV. Here, if you try to locate that the patient has an irregular heart rate, the contractility is not normal. Liver, and this is the IVC. So we are seeing a thrombus in the IVC, a freely floating thrombus in the IVC. What about this? Now this is kidney, and there is a lot of muck around the kidney, and this is perinephric abscess which has happened in the kidney parenchyma itself, and this is the capsule. So this was one of the patients with liver disease who came in septic shock, and we found that he had perinephric abscess. Not the right forum to show this image. Now this is what we found in one of the fetal heart contractility in an acute liver failure patient who was also pregnant. So this was an acute fatty liver of pregnancy patient where we looked at this fetal heart here. So if you can appreciate this part, there is a big clot at the apex, at the apical left ventricular apex. Now this is a septa which is visible. So a lot of proteinaceous material will be there in this fluid, and so this is common in tuberculosis and liver disease patients, and this is a septate ascites is what is visible. If you can appreciate this, a tight valvular etiology. So this valve is hardly moving, plus it is irregular movement. So this patient has atrial fibrillation with very, very tight MS, and this is rheumatic heart disease and atrial fibrillation. And this is also confirmed what we see in the Doppler, that there is a flow problem. Look at this image. Can you appreciate this white structure here in the right atrium? So this is a thrombus in the right atrium, a very classically seen white structure, a freely floating thrombus in the right atrium. Plankton sign. Now this is also called as plankton sign. So this is a freely floating lung in a massive pleural effusion. This is the liver, and this is massive pleural effusion. Now if we look at the contents of this free fluid, it is not anechoic, it is not blackish in nature. It has some white dots here. So mostly this is an infected or a blood stained pleural fluid, and this was in one of our patients. We found that it was massive hemothorax which has happened because of coagulopathy, and this was a freely floating lung here. So there is no, obviously when such a small amount of lung is left, there won't be any sliding, it will be a lung pulse only. Vitreous hemorrhage, a very, very scary picture, but a vitreous hemorrhage, when you're doing the optic ultrasound and scanning the eye, you will see this kind of, if there are white dots inside the vitreous, or there is actual blood in the vitreous hemorrhage. Now this patient, liver disease patient, comes with massive upper GI bleed, endoscopy has been attempted, unsuccessful, SB tube, Sengstrom Blackmore tube has been put, unsuccessful, and finally a procedure has been done to take care of this bleeding. And what is this? So this is a stent. Now we very well know in liver what we put is TIPS, right? So transhepatic portosystemic shunt. So this is what the TIPS catheter or the TIPS shunt would appear like. When we are putting an IABP, right? So obviously you're putting it under fluoro, but even without fluoro also, if you're doing it on the bedside, you can see the bulb of the IABP inflating and deflating in the descending aorta. So just by putting the ultrasound probe at the point near the liver, you will see the descending aorta. And if you can appreciate, this is the bulb of the IABP deflating and inflating. This white line, can you appreciate this white line? What is this? This is the pacing lead. So you can also actually attempt pacing at the bedside with the help of an echo. So these are the pacing leads which are visible. So let us try to understand the utility of ultrasound by going through a hypothetical case. So 54-year-old male, 70 kg, he is diabetic, smoker, alcoholic, has high-grade fever with chills for almost 5 days, has upper abdominal pain, and has high temperature 38.8, is tachycardic, hypotensive, and urine output has decreased since previous night. He has already received 3 liters of saline in the ER prior to referral, and saturations are 94% on 4 liters. So how to proceed? We have to put a DD to it. So is this patient having severe sepsis and septic shock? Yes, it looks like that because of a scenario. So we will do the surviving sepsis campaign. We will do the initial resuscitation. Then you will try to look for the diagnosis, antibiotic therapy. If there is a possible source, then you will try to get it controlled. Administer fluid, vasopressors, steroids if independent, blood products depending on the trigger of the hemoglobin, and finally glucose control. So let us start with initial resuscitation, and we all know that we want to administer 30 ml per kg of fluid. So the fluid was administered, and simultaneously we did a focused ultrasound assessment where we found that the lung was sliding. It was A pattern. So the lungs were dry and A pattern. The heart was also normal, and the IVC was collapsing. The heart was looking a little hypercontractile, and the IVC was collapsing. So this is dry lung, empty heart, and variable IVC. This tells us that this patient can tolerate fluid. So fluid resuscitation was done more. So he already had received 3 liters Another 2 liters was given, but he continued to be hypotensive. A central line was inserted, SCVO2 was measured, which was 45%. The lactates were in the range of 5, and the base deficit of -8. Now what to do? You have given almost 5 liters of fluid and the patient continues to be hypotensive. Do I give more fluids, or do I do anything else? Or do I try to achieve the target? So, targets of CVP are controversial. You are looking at MAP, or you are also looking at signs of intolerance to fluid therapy. It doesn't matter that if you're not able to achieve MAP, you just don't keep on pushing the fluids, because if you can have desaturation, crepitations, or worsening of chest X-ray, they will tell us that these are intolerance. But unluckily, these are very, very delayed manifestations, because these are because of the alveolar flooding. What we are looking at, the interstitial flooding, which ultrasound will tell us much, much faster before all these 3 signs happen, which is desaturation and crepitation. And so again, we will do the ultrasound, and what we find here, the lung which was dry, which was A pattern, has become B pattern, right? We are seeing this laser show image. The heart which was hypercontractile is looking full. There is hardly any scope, and the IVC which was variable has become taut. There is no variability in IVC, and this will tell us that the patient's lungs from dry to has become wet. The heart which was hypercontractile or an empty has become hypokinetic, and the IVC has distended. So even if this patient is hypotensive, no more fluid will be tolerated by this patient, because he has already started manifesting the complications of fluid therapy. So if the patient has more than 15% variability with normal ejection fraction, you can still give more fluids, but with moderate to severe LV depression, you can start looking at inotropes and vasopressors. After initial fluid resuscitation, you also look at diagnosis. So when we did an ultrasound of this patient, we found that there was an anechoic, homogeneous collection in the liver, and this was liver abscess, which was identified, and it was drained. Ultrasound guided drainage was done, but the patient continued to deteriorate. The respiratory parameters worsened. There was an increase in distress and an increase in the oxygen requirement. The patient was eventually intubated. In view of all these problems, he was put on a controlled mechanical ventilation. The FiO2 was on the higher side. It was 0.7 with a PEEP of 10, and the chest X-ray had started showing bilateral infiltrates. Now, what is the cause of this worsening respiratory parameter? Why such a high PEEP and high FiO2, and still the patient is not doing well? Is it because of the congestive heart failure due to left ventricular dysfunction? If you remember, the heart had become a little hypokinetic, or this patient has gone into a ARDS secondary to the liver abscess. So go back to the same physiology. Do your ultrasound of lung, heart, and IVC, and this is what you find in the lungs. So lot of irregular B lines, and this is basically what we call as subpleural consolidation. So there is patchy distribution of scattered B lines, anterior subpleural consolidation, very, very pathognomic for ARDS. And when we looked at the cardiac echo, the left ventricular ejection fraction was normal. It was 45, the FAC was 45%. So this was more or less like a normal ejection fraction. So this patient's respiratory worsening was not because of CHF, and it was probably because of ARDS, which has been caused because of the septic insult. So this patient was managed with lung protective ventilatory strategy, and view of refractory hypoxemia, the lung ultrasound was repeated. And then we found that this patient had a collapsed lung with a high PEEP. So lung and liver, they're almost looking similar in nature. In view of refractory hypoxemia and predominant basal consolidation and collapse, the decision was taken to prone this patient. So proning was attempted, and after 12 hours of proning, we have seen this in the previous slide, that the patient's lung had actually opened up. So this patient started with a septic insult, went into ARDS, then had a collapse consolidation. Proning was attempted, and ultrasound gave us the indication that this patient is tolerating the proning very well. After 48 hours of proning, the patient started showing some improvement. There was a decrease in the FiO2 requirement. The vasopressor requirement also started reducing, and the organ function improved. So the patient was made supine after the adequate number of hours of prone, and he tolerated very well. But on day 5, there was again a worsening of the patient status. He started desaturating and he started becoming hypotensive. Now, what is the DD? So is it a new hit? Is it a second hit of sepsis? Or now is there a new onset LV dysfunction? Is there stress cardiomyopathy? Is there a new congestive heart failure? Or is this patient now going to pulmonary embolism? We couldn't give him any low molecular weight heparin or any anticoagulation because of the liver abscess and other problems. So is that the reason or any other cause? So let us repeat the ultrasound. And this is what we found on an ultrasound. When we are doing the lung ultrasound, we see that this part of the lung is not contributing in ventilation. There is no lung pulse. There is no lung sliding, whereas we see a point where the lung sliding is there and we find a lung point. We also look at the heart because we want to rule out the causes of sudden worsening of the hemodynamics, but the heart looked normal. RA, RV were fine. There was no dilatation. The LV contractility was also fine. When we looked at the vessels, the femoral vein was compressible, so there was no evidence of DVT there, and the IVC was collapsing in nature. And this told us that probably this patient, because of ARDS and high PEEP, had a pneumothorax, and this is the reason for this sudden worsening of the patient's hemodynamics. So lung point is very, very classical or pathognomic of pneumothorax. We have seen this in the lecture of lung ultrasound. So the ICD was inserted and real-time visualization of the resolution of pneumothorax was done. So you can see the movement of the lung point from the posterior point to actually a complete aeration of the lung and disappearance of the lung point. So again, ultrasound can be used as a monitoring tool. So you see a real-time resolution of pneumothorax, and sudden the saturation and hemodynamics started improving. Eventually, the patient underwent tracheostomy under ultrasound guidance, weaned off, decannulated on day 14, and discharged in stable condition. So the crux of the case was that you can actually interpret every single event that is happening during the course of the patient. We started with hypotension. We assess the fluid responsiveness of the patient. We also diagnosed the complication of overzealous fluid administration. We looked at ARDS. We also looked at the pneumothorax issue, the cardiac issue. So you can actually assess and reassess various problems that are happening in the patient during the course of the hospital stay. So to conclude, the role of ultrasound is that it helps in knowing us the etiology of the shock. There is a real-time insight into response to resuscitation. You know, is this patient benefiting from resuscitation? Is this patient going to tolerate further resuscitation? Then you can keep on reevaluating these patients. So once you have done a procedure in terms of whether it is fluid administration or whether it is in terms of resolution of pneumothorax, you can reevaluate that whatever I have done for this patient, has it helped this patient or not? Then titrate your management. So even while recruiting your patients, you can understand what is the amount of PEEP that is required for this patient. Will this patient tolerate a PEEP of 8 or 10? So by sequentially increasing the PEEP, you can come to know the lung inflation. So you can actually assess the recruitment on the basis of the lung ultrasound. So it is a limited examination, and it is purely and surely an extension of the knowledge of the clinical state and physical examination. We are not asking you to replace your your clinical knowledge and physical examination skills with the help of ultrasound. It is an addition in that same armamentarium. It is mainly qualitative, very rarely semi-quantitative, and it is a repetitive assessment. So you do an assessment, you do an intervention, you again come back and assess that patient, that what benefit or harm that intervention has done. It may appear complex looking at the type of images, what is the gain, what is liver, what is lung, how to assess for pneumothorax. Yes, it may look complex at first sight, but it is actually a very, very simple technique, and it changes the way you treat and manage these patients. You can change actually the diagnosis of these patients. So it's a very useful technique. And once it is your learning this, once you get accustomed to the machine, the probes, it will become a routine. It will gradually change the stethoscope. I would say this way, it's a visual stethoscope, and sometimes it is very obvious, the finding, sometimes it is not. And whenever you are getting confused, please take the help of your seniors or look for higher competency. Thank you so much.
Discussing about the ultrasound of the aorta. So aorta has basically two parts, the thoracic and the abdominal. Thoracic aorta would be covered in the part where the echocardiography would be discussed. The thoracic aorta would be covered there. In this session, we will be basically covering the abdominal aorta. So for examination of the abdominal aorta, we will use the curvilinear probe, which has basically got a deeper penetration. And we will be examining aorta in both transverse view and longitudinal view. So for performing the examination of aorta, we will need to examine from the infrasternal notch or the xiphisternum area to the umbilicus. And if the patient is cooperative and awake, we can also ask the patient to flex the neck so that the anterior abdomen becomes soft. So while performing the ultrasound for aorta, we need to place the probe in the transverse view and such that the pointer is facing towards the patient's right. Once we have placed the transducer, but the image which we generate will show. So while I have placed my transducer in the xiphisternum, what we can see on the image is that this is the liver, this is the IVC on the right side. On the left side we can see the aorta, which is the pulsatile structure, and below that the anechoic area with the hyperechoic upper border is the vertebra. So now since we have identified aorta, we will decrease the depth so that the area of interest is in focus. So now coming down, as I move my probe caudally, the first branch which would come out of aorta is the celiac plexus. Here we can see, so you should focus on this area now. So this is the aorta and the branch coming out is the celiac. Now this will divide into on the right side, that is the hepatic artery, and on the left side the splenic artery. So as you can see, as the celiac branch is coming off from the aorta, this dividing into the splenic artery and the hepatic artery and the splenic artery. So this is known as the Siegel sign. And as we move further caudal, what we will be able to see is the SMA, the superior mesenteric artery, which is slightly hyperechoic because of the mesentery cover around it, and it generally lies below the splenic vein. So this is the aorta, this is the superior mesenteric artery, and this is the splenic vein, and here lies the IVC. So and as we further move down after branching of the SMA towards umbilicus, we will be able to see the aorta dividing into the two iliacs. So sometimes it may be possible that you are not getting a good image, so you might have to press the transducer slightly on the abdominal wall so that the bowel gets displaced. So after you have examined the patient in the transverse view, it is important to identify the aorta and examine it in the longitudinal view also. So as you can see here, I have placed my curvilinear probe in a longitudinal fashion in the xiphisternum with my patient. Screen. So as you can see here in the longitudinal view, this is the aorta and there are two branches coming off. So this is the cranial branch, which is the celiac branch, and this is the superior mesenteric artery. You can also confirm by putting the color Doppler on these, you will be able to see the color flow. So this was the examination of aorta by ultrasound. It is important because we need to rule out the abnormalities of the aorta which can be emergency in our ICUs, like the aortic dissection and aortic aneurysm. What is important to know is that the aorta in the abdomen is generally less than 2.5 centimeters in size. So any dilatation which is more than that, mostly more than 3 centimeters, can be suggestive of aneurysm. Also, if the patient has dissection, we can see an intimal flap in the aortic lumen while we are doing the longitudinal or the transverse view. So it is important that this examination is done at the bedside so the emergency can be diagnosed at the earliest and can be treated. Thank you. So in this session now we will be discussing about the FAST and the eFAST examination. The FAST stands for Focused Assessment by Sonography for Trauma, and eFAST is basically the extended FAST. So the FAST covers examination 4 areas, that is the right upper quadrant, left upper quadrant, the suprapubic area and the heart areas. That is basically we look for the pericardial fluid. And in eFAST we will be examining the lungs apart from the 4 areas that we have already discussed. So we will begin by examining the left upper quadrant. So as you can see, I have placed my curvilinear probe in the left upper quadrant, slightly towards the posterior axillary line. Indicator or the marker is towards the head of the patient. Screen pe le. So as you can see in this image of the ultrasound of the left upper quadrant, this is the diaphragm, which is a slightly hyperechoic structure. Below that, this granular structure is the spleen, and below that is the kidney. So what we are looking for in FASTly, any fluid accumulation which will appear as anechoic or dark or black on ultrasound, that would get accumulated in the linorenal fossa. In the left upper quadrant, this is space, that is the linorenal fossa, where the fluid would be getting accumulated. So similarly on the right upper quadrant, we will need to examine is the Morrison pouch or the hepatorenal space. So this is the liver, this is our kidney, and this is the area that is the Morrison's pouch or the hepatorenal fossa. Also, while examining the right upper quadrant, we can also look for any fluid accumulation below the diaphragm and above the liver. Third area which we will be examining the FAST is the suprapubic area. So I placed my curvilinear probe in a transverse fashion such that the pointer is towards the right side. So in the suprapubic view, what we can see is this is the anechoic structure lined by the wall. This is the urinary bladder. So any fluid which is outside this would be leading to a positive FAST examination. And also I can move my probe in an up and down fashion, that is cranial to caudal, to see for any fluid accumulation elsewhere around the bladder in the pelvis. So now for the 4th fossa examination, that is the cardiac, we can use both the curvilinear or the phased array probe. I am using the phased array probe here, and I am placed it in the xiphisternum area to look for the subxiphoid view of the heart. This is the 4-chamber view of the heart from the subxiphoid view, and as we can see, there is no anechoic area around the heart. This suggests that there is no pericardial effusion or any fluid which is causing pericardial tamponade. Tamponade here would be suggested by a diastolic collapse of the right ventricle. After we have completed the FAST examination, it is time to do the extended FAST examination. In extended FAST examination, we need to examine the lung, and we need to basically rule out 2 things, that is the pneumothorax and the hemothorax. For pneumothorax, to examine the lungs anteriorly. So I placed my curvilinear probe in the transverse in the longitudinal fashion such that the indicator is pointed towards the patient's head. While examining the anterior of the lung with ultrasound, what we need to rule out is the pneumothorax, which can be done by looking at the pattern which we see on the lung ultrasound. That is, there can be a pattern, there can be lung point, there can be lung pulse. So after you have examined the lung anteriorly on the both sides, at the right and the left, to rule out pneumothorax, it is time to examine for the hemothorax. What we need to do is that we examine the area 4 posteriorly, slightly posteriorly towards the posterior axillary line. We can see the entire diaphragm in its depth with the lungs here, and this is the liver. So any anechoic area which is present here, that is above diaphragm, would be suggestive of any free fluid accumulation which can be blood in case of trauma. This examination also has to be done on both sides. This session covered all the topics related to the FAST and the eFAST examination. Performing these examinations at the bedside in cases of trauma can be life-saving and can help you in making immediate decisions about the further management of the patient. Thank you.
assessing the eye with the ultrasound. Following that, we'll be going in for a transcranial Doppler. In the eye, we'll be assessing the optic nerve sheath also and the surrounding structures. For examination the eye with the ultrasound, we'll have to instruct the patient to close his eyes. If available, you can use a transparent adhesive dressing. If you're not using it, then you'll have to apply a lot of jelly on the eyelid so that it makes a cushion. So especially in trauma cases, we're not supposed to put pressure on the eyeball. Since the eye is the superficial structure, we'll be using the linear probe, the marker to the right. So just put the probe directly on the globe with at least pressure. Finger, you'll have to support the probe on the nose if you're examining from the foot end of the patient. This is the image you will get. Here what you will see the anechoic globe, the blackish thing. The superficial most structure what you see is the eyelid, followed by the posterior chamber. Then posterior to it is the band-like structure is the optic nerve. So from superficial to deep, you can see this is the eyelid actually. Posterior vitreous chamber, since it is a liquid, it is anechoic, it looks black. Posterior to that will be the retina. From the center of the retina, you will see the band-like structure emerging, which is the optic nerve. Fatty structures will be hyperechoic in the orbital area, actually posterior to the globe. So if you had to calculate or to measure the optic nerve diameter, you'll have to use the caliper. Start at the optic nerve beginning at the depth of 3 millimeters. We'll have to measure sheet diameters. The blackish the hypoechoic thing what you see is the optic nerve. The brighter one which is surrounding the optic nerve is the sheath. So we'll have to measure the outer margin of the sheath. So that will represent the optic nerve sheath. So from here to this area, in this subject at this particular point of time, the optic nerve sheath diameter is 0.35 centimeters. For pupillary assessment, what you need to use the linear probe. Only thing is you'll have to apply the probe as horizontally as possible to the globe so that you can image the pupil. Here you can see some anechoic area here. This is the iris. Reduce the depth so that you can see the pupil. If you just put a light on the other eye or on the same eye, you should be able to see the pupillary reaction. So if you put light on the contralateral eye, you should be able to see the pupillary reflex. So that this in cases of trauma where the eyelid is swollen, you are not able to open the eyelid, you can use the pupillary examination to know the pupillary activity. For transcranial Doppler, we have a transtemporal window. The window starts from the lateral angle of the eye to the tragus. This is the line wherein the circle of Willis plane is there. So we have anterior window, middle window, and the posterior window. In any other subject, either one of the three windows will be suitable for examination. Through this, we insinuate the circle of Willis, especially the middle cerebral artery. So with the use of a phased array probe and a software which is optimized for transcranial Doppler, the marker should be facing towards the front. So we'll have to keep the marker as parallel to the circle of Willis in the line of lateral angle of the eye to the tragus and try to obtain image wherein try to identify the cerebral peduncle. So cerebral peduncle is a structure which lies at the level of the tragus line. Once cerebral peduncle identified, this is the cerebral peduncle. So once it is obtained in the tragus line, you'll have to decrease the depth to 10 centimeters. Circle of Willis is around, the MCA will lies anterior and lateral to the cerebral peduncle. So we'll have to put the color window anterior and lateral to that. So should be able to appreciate the vessel. Color will show the flow in the MCA. This is the MCA actually. ACA we are not able to visualize completely. So the portion what we are interested is the M1 portion, that is the proximal portion of the MCA. So apply Doppler there and obtain the spectral Doppler. So in the spectral Doppler what you see is the systolic waveform, end systolic waveform and the end diastolic waveform. To obtain the different flow velocities, we'll have to use the software. Just trace the waveform from the baseline, systolic to diastole. So the software automatically calculates and give you the flow velocities. So the different flow velocities, what we can see is the systolic velocity here, then the end diastolic velocity, then the mean velocity. We have a PI here, pulsatility index, and the resistantive index. The PI should be around 1, the RI 0.65 to 0.75. In space occupying lesions, what happens is third ventricle will be shifted to the opposite side. Suppose there is a hemorrhage here or a space occupying lesion here, this third ventricle will be shifted to the opposite side. This will help in assessing the midline shift in our trauma patients. That concludes disability assessment of the patient with the help of optic nerve sheet diameter estimation as well as transcranial Doppler. Know the midline shift, we'll have to image the cerebral peduncle here, then just angulate the probe 10-15 degrees up. So we'll be able to see the double reflex of the third ventricle. This is the hyperechoic third ventricle, you'll see.
So now we will move on to the next session, which would be on the deep vein thrombosis. In this, we will be examining the common femoral vein and the popliteal vein, and the transducer which we will be using is the linear transducer, as these are superficial vessels, so it will be easier to examine with this transducer with more clarity. Examining the femoral vessels in the inguinal area, and I have placed the transducer with the indicator towards the right side of the patient, and as you can see there are two vessels which are prominently visible. One is the more oval shaped, another is little flat. So the oval one has a more thicker wall and is pulsatile, so it is the femoral artery, and the other is the vein, femoral vein. So what we can do is we can confirm this by putting color Doppler, and we can see that there is flow in both the vessels. Other thing which we can do is confirm the flow in the vessels. So we can use the Doppler, flow Doppler. Femoral artery flow would be pulsatile flow, while in the vein, femoral vein, the flow would vary with the respiration, and this flow is suggestive of a good flow in the vein. So we are also examining the vessels in the longitudinal view. So here what we can see is the superficial structure of the two anechoic tubular structures. First one is the femoral artery, while the second one or the lower one is femoral vein. We can again confirm this by putting flow Doppler. So when we are putting the flow Doppler in the lower anechoic tubular structure, which is most likely the vein, what we see is a good flow with the respiratory variation, which suggests that there is unlikely occlusion or obstruction to the flow, thus ruling out most likely DVT. Also there is a compression test which is been described in the textbooks, but it should generally be avoided because there is a risk of dislodgement of the thrombus and causing PE while examination. We have examined the femoral vessels. The next major vessel which is to be examined for DVT are the popliteals. We are examining the popliteal vessel, that is the artery and vein in the popliteal fossa. I have flexed the knee and rotated the leg outwards. So again we have to perform the similar exercise which we have done in the femoral vessels. So we can look for the Doppler flow in both the vessels. So this flow suggests the arterial flow because it is pulsatile, and if you are putting the flow into the vessel which is on the right side, the flow which we get has respiratory variation. So this suggests good venous flow, which unlikely has any obstruction. Also, we can confirm the flow by putting color Doppler. So we can see a good color flow in both the vessels. So you can combine your DVT examination with the assessment of the right heart to rule out pulmonary embolism, which can be life-threatening emergency. So any patient who is presenting to you with the A pattern in lung but who is hypoxic, hemodynamically unstable, always scan the lower limb veins to rule out DVT. Thank you. We will be discussing about the procedures by USG guidance. In this session, we will be discussing the procedures on the vascular structure, that is the vein and artery, and how to cannulate them. There are two techniques which are advised or has been described for assessment of the vessels and for doing procedures, that is the transverse approach and the longitudinal approach. And also there are two ways which in which the ultrasound procedures can be done, that is the static technique or the dynamic technique. In static technique, basically you use the ultrasound probe, mark the point of insertion and do the procedure then blindly. While in dynamic technique, the needle is guided throughout by the ultrasound. We strongly disagree with the static technique and we advise for going with the dynamic technique. Now coming to the procedure on the IJV, internal jugular vein. So as you can see here, we are assessing the IJV by the transverse approach, and on the screen you can see the superior structure, which is has a variable diameter with respiration, is the internal jugular vein, while the lower, more oval structure which appears to have a thicker wall is the carotid artery. So if we are doing the procedure by the transverse approach, what we need to do is follow the Pythagoras theorem. That is, what is the depth for the point of insertion of the needle should be equidistant as the depth of the vessel. The depth of the vessel is roughly around 2 centimeters. So our needle placement should be roughly 2 centimeters from the probe. So this is the longitudinal view of the same vessel, that is the IJV, where the indicator is pointed towards the head of the patient. See that we can see the entire tubular length of the vessel through longitudinal view. So advantage is that when you are inserting your needle, you can see the entire tract of the needle where it is going, while in transverse view you are just seeing a point of needle which is transecting your path of the beam. So when you are doing the procedure in the longitudinal view, your needle should be as close to the probe as possible in the midline, and the indicator will help you in guiding the direction of the needle from where it is coming. What we are visualizing is the axillary vein. So we can cannulate this also for a central venous access. Again, this has to be done in the longitudinal fashion. So you have placed our probe just inferior to the clavicle at an angle such that we can see this vein which is having respiratory variation. We will be inserting our needle just as close to the transducer as possible in the midline. And if we follow this vein medially, this joins to form the subclavian vein. So the subclavian vein can also be cannulated. So if we are doing it laterally, we can cannulate the axillary, and if you are doing it medially, we can cannulate the subclavian vein. So now what we are discussing is the radial artery cannulation. So I have placed my probe in such a fashion in the longitudinal plane that the pointer is towards the hand of the patient, and as we can see, an anechoic area which is pulsatile in the upper part of the screen is the radial artery. So again, the point of insertion would be same as the vessels, venous vessels. So you insert the needle as close to the probe in the midline here. So it is also very important when you are doing the procedure to maintain the sterility of the area and the devices which you are using for procedures. So there are two ways majorly in which you can drape the ultrasound probe while doing the procedures. So we'll discuss one by one the two procedures. First one, we'll be using the camera cover, a sterile plastic sheet, and my colleague will hand over me the sterile sheet. So I've taken the sterile disposable camera cover. I'll open it. maintaining the sterility throughout the procedure. So I'll take out this cardboard and my colleague will place the probe inside this camera cover. So now we will add a liquid medium. There is no need to add jelly as it becomes quite messy affair. So we'll be using AHD for this procedure. So once we have inserted AHD and this which makes a contact with the probe, I'll just pull this so that the sterile sheet covers the wire and hand it over to my colleague who is assisting in the procedure. Now I'll make a tight seal with the plastic which has a thin film of the liquid between this and the probe, and tighten the plastic with the sterile rubber band which was provided with it. So now my probe is ready to do the procedures. Now I can just dip this into the AHD solution or a saline solution and use it over the patient to perform procedure. So the second technique of draping the probe would involve using a sterile sheet and a disposable transparent adhesive tape. So my colleague will hand over me a sterile drape. So I will open it and he will also hand over the probe in an upright fashion to me, and I'll hold the probe with the sterile sheet and drape the sterile sheet around the probe as such, like this. And now I will put a transparent adhesive tape over this. So make sure when you are putting this tape that there is no air between the tape and your probe, as if there is a air it will hinder your image formation and will make the procedure difficult for you. So again, we have not used any jelly and we will be using an AHD or a saline solution and dip this probe into it and perform the procedure. So this brings us to an end of the session on the procedures. Thank you.
So good afternoon.
Good afternoon, dear friends. We have already completed the bedside demonstration as well, and I'm sorry that we can't have any hands-on session in this virtual conference. And I hope that you have enjoyed all the lectures and the bedside demonstration. So if you have got any questions, please let me know. I am already having few questions which I would like to answer here. Dr. Shashi Kumar has asked to mainly Dr. Pradeep DeCosta how to differentiate chronic pulmonary thromboembolism from acute pulmonary thromboembolism. With ultrasound, sometimes it has become very difficult to understand what is going on unless we have got a previous recording of the patient or previous examination documenting the same. Is there any way to suspect acute pulmonary embolism in a patient with pre-existing RA-RV dilatation due to COPD or any other cause of pulmonary hypertension? No. With ultrasound, again, it becomes very difficult to identify, because what we are looking here is the enlarged RA-RV and increase in the pulmonary pressure. But if RA-RV is already pre-dilated due to some pre-existing disease, it becomes very difficult to identify the thing. Only silver lining here is if we are able to demonstrate the deep venous thrombus, then we are sure it can give you some light that it is because of the pulmonary embolism. But if the deep venous thrombosis is absent, then again it becomes little unlikely to have a pulmonary embolism. Doctor, I hope I have replied the answer. Dr. Zaikov Joshi has asked the role of CTPA angiogram in the pulmonary embolism. Of course, CTPA is one of the gold standard. Nobody can replace it. But certainly at some point of time when your patient is very hypoxic, unstable, hypotensive, and you are not able to shift the patient to the CTPA, at that time one can rely upon the demonstration of the RARV dilatation along with the high PA pressure plus deep venous thrombosis to identify the pulmonary embolism. Dr. Joshi has asked another question. Extravascular lung water, are you monitoring in the ARDS patients? Yes, of course. Everybody is monitoring. Those who are well proficient with the ultrasound, they are monitoring extravascular lung water in the ARDS, and not only in the ARDS, all the patients where we are giving aggressive fluid therapy. So extravascular lung water is a good indicator of the capillary leak, and you can monitor. If there is any other question, please let me know. Neeraj, do you have any other questions? Neeraj, can you confirm?
No, sir.
So if there are no other questions, I would like to conclude this session. The recording of the today's session is available till midnight today. You can come back again, whatever is left, you can see it again, you can go through again. And mind you, don't forget to collect your certificates. Certificates will be available this afternoon from the exhibition hall. And one can collect certificate anytime from the Premium Partner Lounge. There is not Premium Partner Lounge, the Premium Partners in the exhibition area. There is an icon on the side of the stall. Once you click the stall, then there will be an icon on the side of the stall where you can click and you can download your certificate. We are planning to start certificate distribution from 4 o'clock, but it might get little delayed because we have yet to receive the signature and authority letter from Maharashtra Medical Council representative. He has already been supplied all the passwords. He is monitoring all the workshops, and probably within 1 hour, he will be giving his signatures and the authority letter. What happens in any medical council, they don't give the authority letter prior because they want to be distributed the certificate at the last moment. So he is already monitoring this workshop. Is there any other thing? Please let me know. Thank you very much for attending this workshop. And I would like to thank all my co-faculty for sparing their time and making this happen. Side by side, I welcome you all to and request you all to join tomorrow morning session from tomorrow morning onwards for 3 days conference sessions. Thank you very much. Have a good day. Thank you again. Neeraj, we can conclude the session and start the recordings again. Thank you very much.
Noted, sir.